Good morning, good afternoon, good evening, wherever you may be. Honorable ministers, senior colleagues from government all over Africa, WHO and partner colleagues, distinguished participants, ladies and gentlemen. My name is Dr. Ambrose Talisuna and I am Program Manager for Emergency Preparedness at the WHO Regional Office for Africa in Congo-Brazzaville. I'll be your moderator for this session, and I would like to warmly welcome you to this webinar on COVID-19 response, sharing best practices and lessons learned. Let me first request my colleague, Dr. Bukari, to give us the housekeeping rules for this webinar. Over to you, Bukari.
Okay, thank you, Dr. Talisuna, and welcome to this webinar. As you know, this session is interpreted into French and Portuguese, and you have to choose the language you want at the interpretation. Also, please reserve the question and answer function. Use it for your questions. Use the chat function for other questions related to technical and logistical issues. The session is being recorded and your attendance is a consent to be recorded. In 2 to 3 days after this session, you will receive a link to the video and all the PowerPoint presentations. Thanks and good deliberation. Over to you.
Thank you very much, Dr. Bukari and colleagues. This is a very important webinar. We all know that the COVID pandemic is progressively spreading almost everywhere in Africa. At present, there is community transmission in many countries in Africa. Being a novel virus, the epidemiology is evolving and lessons are being learned in real time. Building on the progress achieved to strengthen preparedness to mitigate risk of potential public health emergencies, all countries must be vigilant and continue to develop capacity to prevent, detect, investigate, and timely respond to COVID-19. While the need for rapid training increased, many countries instituted public health and social measures, and these measures gravely affected our usual training approaches. To respond to this challenge, WHO, in collaboration with the University of New Mexico and the College of Physicians and the College of Nurses, developed this program so that we can deal with the COVID-19 while addressing the context of lockdowns. The objective of the program is really to strengthen health worker knowledge and share best practices for COVID-19 preparedness and response. 2, we also hope that we will improve health workers' comprehension of the critical pillars of the COVID-19 preparedness and response. We want to create also communities of practice targeting different health work cadres. We want to ensure timely dissemination of credible information in terms of guidelines and all the credible information to all health workers on the continent. And I think we are also using this platform to create a virtual learning community of practice for south to south collaboration, but also for south to north collaboration. And this best practicing session really is very, very critical. Since the 1st of April, we've done about 15 webinars. We are doing 2 to 3 of them. As of today, we've trained about 8,500 diverse participants from different areas of the continent. We've addressed diverse topics such as clinical management of severe acute illness, surveillance, laboratory diagnosis, case management, infection prevention dedicated to nurses, asymptomatic transmission and the role of antimicrobial therapy, differences between droplet and airborne transmission and the implications for transmission and control, psychological support for nurses caring for COVID patients, and how to design a COVID-19 treatment center. This week we have had sessions on mental health, which was very critical, and yesterday we had a session on nutrition. We have also had sessions for anesthesiologists and anthropologists. So this is really how we are doing this, and our regional director is particularly interested in this. She would have loved to be here, but she's chairing another session preparing for the World Health Assembly. But she did a recording, and I'm now requesting our host to play the recording from our regional director. Please join me in welcoming Dr. Moeti via recording to this session. Over to you, the host.
So,
yes, I'm here.
yes, can you play it?
Yes, please.
Dear colleagues and ministers of health across Africa, as well as our partners and WHO colleagues, I'm very pleased to join you for this first session in our webinar series on sharing good practices and lessons learned among countries. This is something I thought is very important for us to do. Together, we're learning from countries in Asia and Europe and seeing how we can adapt some of their experiences to the context in our region. At the same time, African countries are demonstrating best practices and innovations and are making progress in fighting this pandemic. And these experiences can be tremendously helpful in all of our work. Already, lessons learned from past epidemics are informing how we respond to COVID-19. Capacities in coordination, surveillance, and infection prevention and control, strengthened as part of the Ebola preparedness, are being leveraged in the response. Diagnostic assets from HIV and TB programs are being repurposed for COVID-19 testing, and the polio infrastructure of community networks, expertise, and real-time surveillance are being used in the COVID-19 response in some countries. This series will build on our work together and inform WHO's strategic, policy, and technical guidance to countries and partners. And so I thank you very much for having joined us. I'd like to commend African governments for your leadership in responding to the COVID-19 pandemic. Many countries have established high-level interministerial task forces, and with the support of WHO and partners, incident management systems are in place to coordinate the response effort. Most governments have moved quickly in implementing measures to limit mass gatherings and facilitate physical distancing, thereby slowing the spread of the virus. Public health measures are also being scaled up and will need to remain in place at every phase of the response and should be in place in every community. These measures are surveillance, finding and testing cases, isolating and providing care, tracing all the contacts and isolating them too. As of this week, the COVID-19 pandemic has now reached all 47 countries in the WHO African region. There are more than 50,000 confirmed cases and 1,500 people have lost their lives. We are concerned that more than 1,600 health workers have been infected. With shortages in many communities, when health workers are not at work, communities face reduced access to essential services. We must do more to ensure our frontline workers are protected and can provide care safely. In closing, I'd like to thank the first 8 countries, Angola, Cote d'Ivoire, Ghana, Nigeria, Rwanda, Senegal, South Africa, and Uganda, for being the pioneers in this webinar series and for being the first to share your experiences to contribute to our collective learning. Thank you.
Okay, so now let me take you through the agenda for our webinar today. If I may be allowed to share my screen. So the agenda for today is really comprehensive, and we've already had the first 2. So we're going to start off with Professor William Ampofo from the Noguchi Institute of Medical Research. He is going to talk about Ghana's experience in scaling up testing strategy. As you know, Ghana has really had some innovations that they have done in increasing their testing strategy. And then we will move to Professor Amadou Sall, who will talk about laboratory testing strategy and decentralization of the COVID-19 response in Senegal. And then we will listen to Nigeria. Nigeria has had experience in both responding to the COVID-19 in Abuja and Lagos. And we have two presentations from Abubakar Jafia and Dr. Oyeladun Okunromade, who will talk about coordination, surveillance, and response for COVID in urban settings and cities. We'll then have a question and answer time, and I encourage you to post your question and answers, like Bukari said, in the Q&A session and not the chat room. Then we'll go to the next set of presentations, and these are really from Cote d'Ivoire, and we will listen to Professor Kajo talk about laboratory testing strategy and decentralization of the COVID-19 response. And we'll have Albert Tuyishime from Rwanda talking about their experience and also deep diving into the management of imported cases and cross-border collaboration in Rwanda. We'll have the second Q&A session, and then we'll go to the final we'll have Uganda will also present Dr. Henry Chobe, who is Lieutenant Colonel Dr. Henry Chobe. I know Dr. Henry Chobe, who will present Uganda's experience in the management of COVID cases and how they have integrated multi-sectoral approaches. So there will be those three presentations, and then we'll go to a Q&A. Then we'll have the final session where we are listening to colleagues from South Africa, and we are very glad to have Professor Koleka Lisana, who is really the executive manager of academic affairs, and she will present on wide-scale testing and addressing community transmission in South Africa. And finally, we'll listen to Dr. Mufinda, who will be talking about Angola's experience and how they have coordinated it, early mechanisms of implementing lockdowns, and they are beginning now to relax their lockdowns, and we will be sharing that experience. So with that introduction, I would like now to invite our first presenter, Dr. William Ampofo from Noguchi Institute of Medical Research. Dr. William Ampofo, please.
Okay, good. Can you hear me?
Yes, please. Over. Super, super. Please share your slides.
Let me figure out how to share my slides. Share screen. Okay, share screen. Share. Okay, is that all right? Can you see the screen? Okay,
Yes,
can everybody? Yes, okay. So
yeah.
I'm actually going to use just one slide for this talk about how we were able to scale up, testing for COVID-19 in Ghana. 5 key points: the logistics, of course, the human resources, the infrastructure. Another issue has been the data management. And of course, we were able to do a large number of testing because we used the pooling approach. But all this would not have been possible without the high level support we've enjoyed from the highest level of government. So let me start with one issue which I think has been a major challenge for everybody. Pet tips, ending at gloves, going through to PPEs. Yeah, that has been, a major issue. And in trying to scale up, we've had to rely on pre-positioned research project supplies. So in the beginning, we were trying to procure from our usual suppliers. And due to the global situation, we found that it was very impossible. So what we did was that we resorted to the local researchers who already had various kinds of supplies for ongoing projects, research projects. And this is what enabled us to provide testing for COVID-19 that served as the platform for testing in Ghana. There are two main testing centers in Ghana, the Noguchi Institute, where I work, and of course the Kumasi Center for Research Tropical Medicine, also based in the second university, KNUST in Kumasi. So these two research labs, were able to provide the foundation for testing because they had research projects which had logistics already available. Then, of course, we built this on. Secondly, because these two research facilities have experience in molecular diagnostics, it also provided the human resources to conduct the testing. So these were, two critical factors in helping us push forward testing for COVID-19 in Ghana. Availability of lab supplies from the research projects and availability of people who knew how to do PCRs because they were trained already from the research that was ongoing. And of course, the existing infrastructure input both at KCCR in Kumasi and also at Noguchi. We have a brand new advanced research laboratory building, which was just inaugurated last year. It cost about 20 million. Very grateful to the government of Japan and the people of Japan. It is this facility that has enabled us to do so much work in the short period of time. You can have the human resources, you could have the lab supplies, but we have about 20 laboratories, each of them fitted out with biosafety cabinets, serving the virology department, serving the bacteriology department, serving the immunology department, which were available to take over to use for COVID testing. And this has enabled us, to also do a large amount of work. How were we able to do these thousands of samples that you hear about? From the beginning, we adopted a pooled approach, where we would pool 5 samples, and then we would then do the extraction, and then we would then do the PCR. Now, we were confident that this was not resulting in loss of sensitivity, because what we did was that we did trials. We took samples that were at the borderline of the real-time PCR, the cycle, the threshold. We took samples that were borderline, did the appropriate, dilutions with other negative samples, and we were still able to detect the samples at the limit of detection, the cycle threshold. And we did this for each kind of PCR kit that we used. So first we started with an in-house assay from the Rocky Mountain lab in the US. Then we had from Africa CDC, WHO, and WAHO, we had a TIPMO Bio PCR kit. We again did this, analysis. And then we had the Dan Gene PCR kit, which is a donation from Jack Ma, which the government has also purchased. So for each type of PCR kit, we determined the level of sensitivity for the pools that we were using. And we found that we could actually increase the number of pools to 10. And this enabled us then to really push forward and test a large number of samples in one session. And this pooling approach was being used by both KCCR in Kumasi and also by us at Noguchi. As I said, the infrastructure has enabled us to do this very well. And we then established the lab protocols for sample collection and also for data management and reporting the results to the Ghana Health Service and also to local WHO office and to partners. All this has been possible because of the very high level support that we have received. Right from the beginning of the declaration of the pandemic, government formed an interministerial task force, which is chaired by the president himself. And this task force meets regularly, and the different sections are charged to provide timely reports on the status quo. And resources have also been provided directly by the Ministry of Finance, the Ministry of Health, and to the Ghana Health Service. And this has enabled us to reach out to suppliers who can provide identified things, and we'll be able to move on. One thing, for example, we did was when we could not get swabs, we quickly changed to sputum, and the local Global Fund program released sputum containers from the TB program, and this enabled sample collection to proceed. So we adopted not just nasopharyngeal and oropharyngeal swabs, but we also adopted sputum sample collection throughout a lot of the sites. They enabled us to push ahead and continue screening when swabs were not available. With regards to data management and reporting of results, one major lesson we've learned is to move from paper-based to electronic. So we recently adopted a barcode system where there is an app which is internet-based, and the field teams collect the samples and they enter the app on site in the location where they are, and the sample with the barcode is then transported to the lab. We scan the barcode and we're able then to access the information that accompanies the sample, and then directly using this app, we report the results online. This is gradually being rolled out, and we now have 7 testing centers in Ghana covering the southern sector, middle sector, and the northern part of Ghana. We're also looking to utilize the Gene Expert platform, which is in almost all the regions and several districts of Ghana. And we've had high-level support to put in an order for the kits that will run on the Gene Expert platform. We've also had some discussions about using RDTs for surveillance. And we also have a program currently evaluating commercial antibody tests through our National Food and Drug Authority, which has established guidelines for the evaluation of these RDTs. We've also, as you heard before, we've done some sequencing of the initial strains that we found in Ghana, and we have deposited these sequences onto the GISAID platform, and we are proceeding to develop the manuscript for publication. So in a nutshell, this describes our approach to COVID-19 testing. We've used a pooled sample approach. We've expanded the testing from the 2 main labs to peripheral labs as well. Government is providing supplies to ramp up testing in all these centers. And the testing is based on direct detection of the virus. PCR is the main focus now. And we will continue with this approach until government feels that another strategy is required. And government is doing tracking, testing, and treating as its main approach. So this is what I have for the experience from Ghana. And we're very happy that we're sharing this experience with others. It's not been easy. We've had teams working day and night. You know, we do 24/7 in the 2 main centers just to keep up. And we've been able to clear backlogs of samples, and we're trying now to provide data on a real time, at least 1 day after we receive the samples. There are still some challenges, but we're learning ourselves, and we hope that it's not an easy approach, you know, testing thousands of samples each day. But sometimes it is a struggle, but we have to manage to find the resources from the supplies available and push on with the work, because we have full support from the government. And just to motivate the labs that have been involved, we recently received vehicles from the National Trust Fund that has been set up. So each laboratory that is working right now on COVID has just received a vehicle, brand new vehicle. And this is a good source of motivation to the staff. Government has also provided some tax incentives and salary top-up to frontline health workers. And this is also a good motivation to staff. Over to you, Ambrose. Thank you.
Thank you very, very much, William, for sharing that Ghana experience. So we will now move on to, and William, please stay on, because there are questions that we will have during the panel discussion. And I would like now to invite my senior colleague, Professor Amadou Sall from Institute Pasteur, and is going to present on Senegal's experience. Professor Amadou Sall, please.
Thank you. William, can I share my screen? I think you, okay, thanks. Thanks, Ambrose, and thanks to WHO for bringing all of us here. I'm just going to present the Senegalese experience. So welcome to Senegal with these pictures. This is a situation in Senegal where today actually we have several different health districts, and we have 2,310 confirmed cases, 819 recovered patients, and 25 deaths. And so far up to now, we have been testing a little bit less than 30,000 samples from our lab in Pasteur Institutes. So what you can see is this epidemic curve where we have much more cases that has been detected in the recent days, and actually the last week is just ongoing. That's why it hasn't reached the other different part. But what has been notably important is that over this week, I mean, we have like a huge increase in terms of sample to be tested, because what you can see in this graph at the bottom is that the number of positive, but the increase of samples over times, which has been done like more than 10 times within the months, between March and April. It's turned out 10 times because the government actually, as a strategy, have an active surveillance for community-based active surveillance, which is important to deal with community cases. And so the testing is for suspect case, for contacts, and patient follow-up. In the next slide, I'm just going to focus on the scaling up of laboratory testing, which has been mostly based on reorganization and innovations. Some digital platform for data management and trying to get the result back, and also for decentralization. In terms of reorganization, I mean, we have this very different step in the process because we're doing PCR about inactivating extractions and RT-PCR. Where the testing right now is about 1,000 to 1,200 tests a day. And the implication is we have to work in terms of human resource 24/7. We have tried to get automation quite highly because many of the steps have been automated with quick PCRs and automated extractions. And the biosafety logistics has been safety also has been important. You can see on these glove box that are very important to scale up the biosafety. And obviously data management is important. When you receive 1,000 forms on which there are a lot of information about the patients, you better have the data management team that can go through that and get the right information. Now, the second important aspect I want to talk about the lab, which is more complementary but important to know, is sequencing for contact tracing that the lab has to do. Because with community cases, we need to know how to connect some of those cases with any kind of transmission chain. Evaluation of diagnostic is something that the lab has to do because with the RDT or with the molecular testing, there are more and more new rapid tests that are coming, and what we want to be sure is we have the most efficient one. So as part of the lab activity, we have to do evaluation of diagnostics assays, RDTs, ELISA, and at the same time molecular testing, was a quick one or a regular one. And obviously the lab has to support since we are following patients in clinical research, trying to see what's the best treatment for the patients. In terms of innovation, I just want to emphasize the fact that we have to plan for the next much larger testing where RDT may play a key role. So we're talking about actually antigen or antibody. And right now there are a lot of evaluation going because our lab is a center of excellence for Africa CDC for RDT evaluation. But also because Senegal has been developing this partner in RDT that's going to be rolled out starting in July. And the second molecular testing that is happening is also a 15-minute test for molecular tests that we call RPA. So all these are ongoing and along with the testing, because we believe that the testing is going to make a huge difference at some point. In the next slides, I just want to talk about the second part, which is more like the digital platform. And what you can see in these slides In Senegal, we have developed a platform that we call Teranga. Teranga meaning like hospitality because it's more like an open platform. And in this open platform, we have all the different chief medical officers through that platform from the lab can have access to all the different patients and results. This is very well regulated because each of the district health chief medical officer can see on these districts. But the good thing is they can download the result and they can have the information directly from the lab. The Minister of Health has insisted to make sure that we can have action quick, meaning that since they can get the result and they can take action into informing the patient and if they have to isolate them or treat them to be able actually to know. But in the same platform, we have also a laboratory model where since we have different labs actually that are testing in the field, through this centralized system, you can validate all different labs and from our different sites, senior people can see the results and validate them and then it can get accessible to the people in the fields. The same system is actually putting together some results as you can see here, where you have detailed information. But also where you can have a QR codes that's for the patient to verify really the source of the information and make sure that these results are authentic. Because in Senegal, at some point, we faced some people saying that they were doing testing and this was not really true. So we make sure that we authentify the result. And the last part, all the information collected can help also to have some kind of outbreak dashboard where you can have information about the testing and all the information you get with a form that can be actually exploited and be available for the Minister of Health and to manage the epidemic. The next slide is, sorry, I think I don't, yeah. This one is about decentralization. In Senegal, we have a central lab at Institut Pasteur at the capital, but we have two other peripheral labs because the Minister of Health has requested us to make sure that we get the earliest possible test happening. So we have one in the central part of Senegal, which is called Touba, where we have an epicenter at the beginning of a very strong chain of transmission. And a second lab in the southern part of the country, which actually serve all the country region. And Dakar, where we have mass testing, can get all the different samples from other areas. So meaning that when you are inside the country, you can go to any of those, which is shortening in terms of sample transportation at the same time, which allow those people to be doing testing close to the patient, because this is important in terms of discharging them, for instance. On top of that, we have a mobile lab that is itinerant and that may be search capacity if there is some area that is needed and that can turn to support one region if needed. So far, it has been positioned in Touba because that's where the needs are the most important. But if for some day one of the regions need to have search capacity because some sort of new massive chain of transmission, the mobile lab could go. And also what we're doing, we're training some other lab. And right now we have trained one staff every year from National Public Health Laboratory. And also we're trying to do that for that same staff on request of the Minister of Health, because this would help actually multiply the lab. We have another lab testing right now. And so we're gonna be probably more lab in the coming weeks. So it's all in the decentralization is about the mobility, the testing on site, and also connectivity, because each of the different decentralized lab can either test within the mobile labs, which is the picture that you see with this young gentleman doing the testing in a glove box. But also within the mobile lab, you have connectivity, and this connectivity exists in other central labs. So they can handle the result quickly and they can access to the digital platform to interact with either the physicians or the central labs to do validation of results. Just lesson learned in terms of challenge, information from the field on samples, because the samples are taken by surveillance team. It's very important that information being accurate and provide information so this can be into the platform and can be used for the outbreak management, but as well as interpreting the results, whether people are contact or what are the links, so we can have a pretty good idea when we do that. This is important. Second is supplies. I don't need to elaborate. William touched it. It has been a huge problem, and we have to be innovative. In Senegal, we have tried really to be extremely proactive in trying to buy as much as possible samples, but we're working with Africa CDC to distribute samples and WAHO to distribute samples throughout the different countries as like a hub to do that. And this has been a major challenge. Biobanking is also a challenge because when we receive every day, like now, samples, we want to make sure that each sample has been correctly stored. Data management is something very important. If done well, can be extremely informative, but need a lot of resource in human resource and also need to be adapted on a regular basis about the performance of the platform. Turnaround time is absolutely critical. Every number of samples that we have has, we are working to get them the same day. So no samples stay here more than 12 or 24 hours because it's important for the discharge of the patient. And it's also very important to take action. And the last thing is logistics for the peripheral lab because this need to be provided regularly with reagent and moving stuff back and forth and reinforcing them all the time. I'm just going to stop this and thank WHO for these great ideas and also the different other partners we're working with, which are ECOWAS, through WAHO, as well as Africa CDC. Over to you. Thank you, Ambrose.
Madhu, thank you very, very much. I can see in the Q&A, I'm sure people are still asking, they still need to see a lot more about your decentralization and mobile labs. So please stay online and during the Q&A, we'll read out some of the questions and you respond. So let's move on to our colleagues now from Nigeria. And this is the Nigeria CDC. And we have two presenters from the Nigeria CDC, Dr. Abubakar Jafia and my colleague, Dr. Oye Ladun. So we'll start with Abubakar, please. Abubakar, please, if you can share your slides and present on Nigeria's experience and this control in urban cities.
Yes, thank you very much. This is Abubakar Jafia speaking from the city of Kano. I'm going to share the experience that we have had in Kano. Kano is located in northwestern Nigeria. It's a city that has a population of about 14.5 million people, and 35% of this population, about 5 million, are resident in a particular city, in the Kano city itself. So it's a very big city, densely populated, so you can just imagine what happens there. Prior to having the outbreak in Nigeria, we did a risk assessment of all these states, and Kano happens to be one of the states that it has high risk. Also, because of that, we've followed up all persons of interest, that is passengers coming from outside of Nigeria for a period of 14 days, and we usually allow them to exit if they don't show any symptoms. So we've been following up very well with Kano even before the outbreak. Now, the response structure in Kano is headed by the deputy governor of the state, and it is coordinated by an incident manager. We have all the 6 pillars being coordinated that report through the incident manager. The pillars are, we have surveillance, we have lab, case management, we have the infection prevention and control pillar, we have the risk communication pillar, and lastly, the logistics pillar. Now, whatever, all the plans, before the outbreak, pre-incident action plan was developed, and during the outbreak, it became an incident action plan. And so all these pillars have their own activities lined up within the IAP, and then the coordinator, the incident manager coordinates that generally. Now, there are critical timelines also that I need to mention as far as this outbreak is concerned. Kano State activated their incident management structure for COVID-19 on 20th of March. And of course, Kano detected its first case by 11th of March, and then response started thereafter as from 12th. Also, just to mention that at some point, some of the members of the task force tested positive for COVID-19. So that created some form of gaps as far as the response was concerned. So the EOC has to be shut down by 17th of April, and it took about 4 days before a new IMS structure was activated. You know, so that kind of posed some challenge to the response. It brought about some disorientation, lack of focus, but thank God, after the inauguration of the new structure, everything is going on well. So most of the activities around surveillance included case detection and alert management, case investigations, contact tracing, active case searches, and of course, the need to increase sample collection sites. I also mentioned briefly about data management and reporting. Now, for case detection, there are toll-free lines that everybody within the state can call, and these alerts will be investigated by a rapid response team immediately. Once the alerts are received, verified, and immediately they are responded to. So the toll-free lines are 3, but they have a capacity to receive 120 calls at a time. Now, this is operated by about 24 personnel on 3 shifts, and there are plans actually to scale that up immediately. Now, the rapid response teams that I've mentioned about are composed, it composes of a clinician, laboratorian, and an environmental officer. So once they receive an alert, they go verify and take samples immediately for laboratory investigation. Also, closely related to that are the contact tracing teams. They work directly with the case investigation teams. Once a case is identified, these contacts are line listed, and then they are being followed up for a period of 14 days. Now, for the contact tracing teams in the metropolitan LGS, we have about 4 teams going to each LGA. These 4 teams comprises of 2 trained personnel that move from one house to the other, following up the contacts. Now, so far we have line listed almost about 1,300 contacts, and most of them, are being followed up. Some of the contacts have also converted to confirmed cases, yeah. And another closely related activity to that is the active case search, because we have seen that there is community transmission within Kano. We do active case search. Communities have been identified where there are clusters of these cases, and then these active case search teams move from house to house, asking questions, going to facilities, reviewing their records, and so that we get cases. And in doing that, we have visited about 80 communities and over 60 health facilities. While we are doing that also, we sensitize the communities on COVID and how to stay safe. Because of the challenge in a city, getting to ensure that people are tested is difficult, we increased the number of sample collection sites. There are 4 sample collection sites currently within the metropolitan LGS, and then also 1 each in the zones is being planned, and then 4 additional for the metro LGS. Currently, on a daily basis, we collect about 180 to 200 samples. Sometimes it goes beyond that. And then so far we have tested about 2,148 samples. Of this, 707 are positive. Now we have 3 functional laboratories in Kano, and these are the 3 functional laboratories listed there. They have the capacity to test about 270 samples daily, but there are plans to scale up this to 1,500 on daily basis. Now, so far in Kano, we have had, like I said, we've had 707 confirmed cases. Most of these confirmed cases, about 90% of these confirmed cases are within, the metro LGS. From this map, you can see the clustering, how these cases are clustered within, this city of Kano. Now, like I mentioned also, 35% of the population of Kano lives within this metro LGS. So it's a huge issue for the state, but with the IMS structure, things are working now. This is just talking to us about the age-sex distribution of the cases and also the deaths by age and by sex. Mainly, you can see from the diagram here, it's males that are mostly affected, and males of the ages of 31 to 40 are the most, affected. Also, you can see that from 0 to 10 years age group are least affected, and the mortality, case fatality rate is highest in ages 70 years and above, has case fatality rate of about 22%. So this is just to show us that this goes to show this outbreak trend also conforms with what happens, what obtains in most parts of the world as well. So what is our challenges? I've mentioned about the gaps we identified initially due to the closure of the EOC because some of them tested positive, but this it's been taken care of now. There are also challenges as far as human resources are concerned. We want to scale up the rapid response teams, but in doing that also, you have to balance with the human resources available. That human resources that we are talking about also, that is what we are thinking about to use for the sample collection sites. For logistics, we have in sometimes you get to see that the PPEs are not enough, consumables here and there not available, and so on and so forth. And then of course we have seen lack of cooperation and denials by cases that have been confirmed. People want their tests to be repeated, don't want to go into self-isolation, into isolation facilities and treatment centers. So this has also been a challenge, but the risk communication pillar has been following up with this to ensure that they sensitize the communities, have some community engagement so that these people are taken into the isolation facilities. And of course, as at now, about 30–40% of mild cases are not within the isolation facilities. They are being managed at home. So without taking so much time, this is the presentation from Kano. I'll allow Dr. Ladun to take the beat from Lagos. Thank you so much.
Thank you very much, Abubakar, for very comprehensive presentation. I know there is a lot to present, but I'm requesting panelists to stick to the time so that we can have some Q&A. So yes, Ladun, now over to you to describe what is happening in Lagos.
Thank you. Thank you, Dr. Ambrose. Good afternoon, everyone. I know the time has gone. I have just about less than 5 minutes to quickly run through. And thank you, Dr. Jafia, for the presentation. Okay, so I'm trying to...
Jafia, you have to stop slide sharing so that Ladun can share.
Yeah.
Okay, so Nigeria, highlighting Lagos State, and Lagos State has a local government of 20, and Lagos State has 1 international airport and the 2 major seaports as well as 1 land borders, which shows that Lagos State has a lot influx of international travelers. And Dr. Jaffe has presented about the EOC structure. It's similar in all the states. Before the outbreak actually started, Nigeria started their risk assessment and did the preparedness phase for all the states, and all the states were mandated to develop their incident action plan as well as their emergency operations structure, which is similar across the board. So I won't go much into, I won't dwell much into this. In terms of the outbreak evaluation, I was just talking about Lagos State. The first index case in Nigeria actually recorded on the 27th of February and in Ogun State, and this was managed in Lagos State. So Lagos State activated its IMS structure on the 27th of February. And on the 7th of March, while managing the first case from Ogun State in Lagos State, Lagos State detected its own first index case. And on the 16th of March, also we had an incident on board the vessel where we had one of the crew on marine platform had tested positive for COVID, and that necessitated the need to quarantine everyone on board the vessel. And following that, we recorded about 60% attack rate. And on the 23rd of March, of course, Nigeria suspended all international flights and announced the first lockdown, which prompted us to increase and as well as enhance our active case search in the community as well as the health facilities so as to rapidly detect more cases and ensure that we identify confirmed cases and isolate them on time to limit community transmission. And following that action actually created demand for a lot of sample collection. And we also accelerated the sample collection by establishing sample collection sites in all the local governments across Lagos State. So we had across all the 20 LGA, we established sample collection sites in all the LGA. And following the lockdown, post-lockdown that was announced on the 1st of May, we developed the second phase of the surveillance strategy in Lagos State. So this is just to show an overview of the updates of surveillance in Nigeria. So currently we have over 5,000 positive cases in Nigeria with 167 deaths, and that gave us about 3% deaths in the country. We have 1,180 that recovered, and actively Lagos State is Nigeria is managing over 3,000 positive cases. And Lagos State has the highest of all the confirmed cases in Nigeria, which is the epicenter of the outbreak in Nigeria. And this is just to show the trend of confirmed cases in the country, showing increasing number of cases in Lagos State. And this shows that now within the community, we're now at the stage of ongoing community transmission in Lagos State. This is the distribution of confirmed cases across all the LGA. All the LGAs in Lagos State have been affected, with the highest in Etiosa local government, followed with Pushofe and Lagos mainland, as well as Alimosho. And the lists involve Badagry and Ekpe LGA of Lagos State. This is just to show the demographic profile. Majority of cases are male, and the highest age group within the 31 years to 50 years of age. I mentioned earlier the marine platform vessel where we recorded the first case in Lagos on the 14th of March of the Ukraine that traveled via the Turkish air and joined a marine vessel with about 50 crew and servicemen on board. We confirmed the first case on the 16th, and following that we had series of confirmed cases from 8, and we had more confirmed cases till April, and this gave us a attack rate of about 60% in the quarantine vessel. Also in Lagos State, we've recorded health workers infection. Close to 200 health workers have been affected, and frontline workers that are part of the COVID response are part of the people affected, and majority of these health workers are in the private facilities. And from the category of health workers that have been affected, we have about 20% of these health workers are medical doctors, followed with nurses. This shows that the health workers are not spared in the line of duty. And in terms of the mortality, this shows the mortality overview of the confirmed cases in Lagos State. Lagos State has recorded about 33 mortality so far, and 72% of these mortality are males, with 27 being female, with a mean age of 51, and 60% are within the age 50 years and above. In terms of the drivers of this transmission in Lagos State, following the trend of progression of the confirmed cases in Lagos, we've noticed initial stage of travel-related exposure at the beginning of the health outbreak. A lot of confirmed cases had history of travel, and then we noticed, of course, the marine vessel, a close space and household exposures to a confirmed case or to travelers were observed, and this prompted a widespread community within the Lagos state. And also, we started experiencing a surge in health workers associated exposure and infection. The surveillance activities that we adopted in Lagos state is similar to what also presented. Like I mentioned, this was developed at the national level and shared across all the states. So I won't dwell more on this. It's still the same strategy of case detection and alert management, case investigation, contact tracing, data management and reporting system. And one thing to note here is we've also rolled out a real-time data reporting system for COVID by scaling up our summer's rollout in Nigeria. So following what we observed and post-lockdown, we realized that most of the activities that are being controlled at the central level will find it difficult to meet up with the rate of transmission in Lagos State. So we developed the phase 2 strategy agenda for surveillance in Lagos State by ensuring that we decentralize our response across all the LGA in the state, and by strengthening LGA-based surveillance teams, ensuring that we have rapid response teams across all the LGA that will carry out case investigation, ensure contact tracing, ensure sample collections across all the LGA, as well as ensuring active case search and for house to house and health facility, all located within the LGA. And this necessitated the need to have a surge in personnel across all these different category components of activities, and ensure that at the central level, we increase our monitoring and supervision activities to ensure that the tempo of the response is maintained. So we developed this flow chart for the LGA team in terms of establishing a rapid response team at each LGA to perform a case investigation. So we'll have personnel of 4 personnel that would conduct surveillance activities at each LGA. That will be part of laboratory personnel at each LGA to carry out investigation. And if there is any suspect case, they will immediately isolate and collect samples all at the LGA level. And this also will ensure that we strengthen the PHCs within the LGA to be able to handle this. And if there is any severe cases, will be evacuated immediately to the treatment center. And one of the strategy of this is just to ensure that at each LGA we also have isolation facilities so as to keep up with the tempo and the number of confirmed cases that Lagos State is experiencing. At the same time, there will be evacuation team also decentralized to the level of each LGA. And that is where we are in terms of the second phase of this strategy. So as not to take too much of our time, what are the lessons that we've learned in this outbreak? We've realized the need to ensure that we strengthen epidemic preparedness at all levels. It goes beyond just strengthening epidemic preparedness and response at the national and the state level, but we need to carry along all the LGA. We need to ensure a well-coordinated leadership by the local health authorities and involve the local health system in all the epidemic preparedness stage. Because the rate at which this outbreak is going, it may stay with us for a long time, and it's not sustainable to be sending teams and personnel at the national and the state level all the time. We need to build capacity of the rapid response team within the LGA, and also the need to further invest in strengthening core capacities across all board. And we also need to create enabling work environment for health workers. Health workers need adequate protection. They need to be well protected and ensure that they have, they can provide their healthcare assets in a very safe environment. And of course, due to, as a result of innovations, research, we need to scale up medical innovations to be able to curb and halt the current epidemics, and with collaborations across all sectors. These are the challenges. It's very similar to what Lagos State, Kano State also presented, so I won't dwell much on that. Thank you.
Wow, Ladun, thank you very much. Very rich presentations. I don't even know how we are going to do justice to the discussion, but I've captured. So I'm now opening these first presentations to the Q&A, and we will have just one round, and I'm going to summarize those ones I've got in English, and then Bukari, you can tell me what is coming up in French from the. If I start off from William's presentation, William, I think the pooled approach is very good, but on 5 samples. But people are seeking further clarity on what the pooling means, and so you might have to try to explain a bit on pooling. They also asked you, have you seen any issues with repeat infections? And then on the use of sputum versus swabs versus saliva, what is your experience on the sensitivity of those methods of collecting specimens? And then I might have missed, but there are some questions that came up yesterday, which Professor Sal and yourself need to answer. One was, what is the experience, if any, and practical guidance for using antibody serological tests for COVID-19 for operational research or for program purposes? And then are the different models adopted and the scenarios put forward by many African countries at the start of the pandemic realized? How close are we to the realities of our? That might be a question that colleagues from Afro might want to answer, that came up yesterday. And then for Professor Amadou Sal, they are asking about the Teranga platform, fantastic platform, but a digital platform. But is it integrated with the national electronic system, or is it just a lab system? And then on your decentralization strategy, there are really a couple of questions. You talked about central lab, peripheral lab, and itinerary mobile labs. And participants are asking, what kind of RT-PCR equipment do you use in the mobile labs? And they also want to explain a little bit more about the $1 RDT test that is, and how you plan to scale that up. In terms of the colleagues from the Nigeria CDC, I captured this. Could you elaborate a little bit more? I thought you had done, but somebody wants to hear more about the contact tracing in Kano State, and how is IDSR implementation in Kano, and is it being used? And what is the testing strategy for the primary contacts in Kano? And then for you, for Ladun, how sure are you about reported deaths, especially at the community level? So could you describe how you're tracking deaths in Lagos? And what is, why is there a high number of cases in LGAs that are referred to as unknown? Could you explain why that is the case? And then what are the measures being put in place to mitigate health worker infections and health worker death? Because we are seeing this now. We saw it also in Lassa fever. So what is being done? Those ones that they want, and then the final one, is there resistance for these interventions? Those are the ones I captured. And before I open it up to the panelists, Bukare, did you capture any in French which you need to summarize? And if they have, I've missed it. Bukare?
Yes, there is only one question not covered by the English one. It's about the strategy used to mobilize additional human resource.
All right, so let's start, panelists, from the way you started.
Okay, this is William. Can you hear me?
Super, we can hear you very well, William. Can you go ahead, please?
Okay, I'm sorry it's so difficult to explain the pooling. So by pooling, we start at the RNA extraction step, where we take individual samples, we take specific volumes. In this case, I think it's 20 microliters, and make this up 20 microliters from each of the 10 samples and put all this together into one vial. So this becomes sample or pool number 1. So pool number 1 is made up of sample number 1, 2, 3, 4, 5, 6, 7, up to 10. So this becomes pool number 1. And then pool number 1 is taken through the RNA extraction step. So 100 samples now become 10 pools. We go through the RNA extraction, we do the PCR, and if pool number 1 is negative, then we take it that sample number 1 to 10 is negative. Then we move on and we continue the process. If pool number 1 is positive, then we have to go back and extract each sample individually. Sample number 1, sample number 2, sample number 3. Each of them now becomes the original 10 samples. Then we run the PCR, and then we find out which member of the pool is truly positive. So because the prevalence has been low, this approach has been cost effective. We have been able to screen a large number of samples within the limited capacity of our laboratories. So depending on the number of PCR machines we are using and the number of people who have been doing RNA extraction, we could do, say, 3,000 samples, process 3,000 samples in one period. So because we are pulling 10 of them, this becomes automatically about 30,000. But this does not mean that we are able to finish 30,000 samples in one session, because we have to go back and unpool the positives. So it enables us to start processing about 30,000 samples, but then we need to unpool the positives as we go along. So it has been an effective approach because of the limited amount of reagents that we were working with. We did not have enough RNA extraction kits at each point in time. So we had to use this method to conserve the RNA extraction kits. And we found that this was quite, a good strategy. And we did not lose sensitivity because each PCR kit that we used, we determined the level of detection when we pooled the samples. So we were able, according to the sensitivity of the particular PCR, and we've used about 5 or 6 of them during this period to be able to determine that truly the samples were positive or negative. Now for retesting, we have a separate database for retest, because you know that in order for a patient to be declared have recovered or to clear the virus, you need 2 consecutive PCR negative results. So we created a separate database, and as positive patients were referred back to us for testing, these patients were then tested again. And of course, we used number of samples we were testing in that particular session. So, but we created a separate database for the retest so that the cumulative count of positives that the epidemiologists use to look at the way the epidemic is going is not affected by the number of retests of positives that we do. I think these addresses most of the issues, the questions that.
Thanks, William. I mean, I really like the pooling strategy. I think countries you really need, you are going to be a hot cake, William, so we will need additional, but you need to write it up and share it, and because I think we need to see how it works. Thanks a lot. Amadou Sal, Amadou, please, you have the floor.
Thank you very much, actually, Ambrose. I understood the question was about Teranga, and actually Teranga has different modules, modules in surveillance, module in lab information management systems, contact tracing, sequencing analysis. These are different modules, some of them very well advanced, some of them still under development. Right now what we're sharing is the laboratory information management system. Whether it's interoperable with the surveillance system right now, no, but this technical capacity exists so far. It's just that we haven't discussed with the Minister of Health right now to make that happen, but technically it is feasible. Concerning the mobile lab, I think asking about what PCR machine are used for RT-PCR. For RT-PCR, we are using the different machine are feasible in sites, are available inside. Some of them that you can bring in, like CFX or Smart Cycler, are things that you can put together. It's very flexible. But the mobile lab itself came with some cassettes that has been the one done by IDELA that is already available. Now, concerning the RDT, the question we have is whether we're using it in Senegal. Not yet right now. The RDT being developed are still in the evaluation process and should be validated by end of June. So right now we have a very good result so far. So but we keep testing it to have the performance the highest possible. The idea also is to make sure that we manufacturing is going to be starting it in July and be available from July to December. We're planning to expand that to million capacity. So that's what I think I remember from this question, unless I've not been exhaustive. Ambrose, is there one I didn't take?
Yes, there is one from my colleague. The WR of Niger is asking, what is the testing strategy for Senegal? Because you seem to be doing a lot of tests. And then I thought you had not talked about the $1 RDT and how you plan to scale it.
Okay, for the testing strategy in Senegal, initially it was focused on people with symptoms and high-risk contact initially. Right now, because of the community cases and the active surveillance, we're testing the symptomatic people that are suspect, and we do all the contacts whether or not they have symptoms, which make it quite large in terms of testing. And when people are confined, contact after 14 days, for some cases, they have been tested before they get released. That's what we are doing so far. And the testing, the follow-up for the patient is that every 3 days, 2 to 3 days, the patient are being tested to see what is their status. About the $1 kits, I just talk about it. It's just that the idea is that we're gonna make that RDT available for $1, which is actually the cost of goods, infrastructures and people, because we have a business model that allow that. There are two tests. One is antigen, which is going to be on saliva, and the other one is on blood, which is going to be focusing on IgG and IgM. Over to you.
Thanks, Amadou. So let's now move to the colleagues from the Nigeria CDC, starting with you, Abubakar, and then Ladun, and then move to the next session.
Thank you so much. The question asked was about contact tracing. I tried to answer that online, but I will also mention the process. Once a suspected case is identified, the process of contact line listing commences. If it is positive, it continues. If it is negative, it is discarded. Now, these contacts, if a case is positive, the high-risk contacts, the immediate contacts are also, their samples are also taken, I said, and also tested. After the first test, they're usually in isolation. They are advised to self-isolate. The high-risk contacts should isolate. And after 14 days, after the first test, after 14 days before they exit out of isolation, they are also tested. Once they are negative, then they are allowed to rejoin their families and the society. But if they are positive, they are taken into the treatment center. And also, a question came up on IDSR strategy in the context of this COVID-19. The DSNO, that is the Disease Surveillance and Notification Officer, is the custodian of the IDSR at the local government level. So all this data about COVID goes through to the DSNO through the Surveillance, Outbreak Response and Management System, which is a digital tool that we use in reporting reporting IDSR. Also, maybe to just provide additional clarity, I mentioned that in each team, surveillance and contact tracing team, there are 2 personnel that have been trained. And in every LGA, you have 4 teams that go around to trace these contacts, to follow them up. And so far, for Kano, we have followed up to under about 98% of these contacts are under follow-up. And 70 of them, just a number, 70, have completed follow-up. So that is that about contact tracing. I don't know if there's any other question for me. I had strategy for additional human resources. I don't know if it is for Kano or if it is for another person. Thank you.
Thanks a lot, Abubakar. I think you've answered your question. Ladun, can you then finalize your questions? I know there are so many questions, colleagues.
I'll try the ones I can remember. So I have the first question on the reported deaths in Lagos State, talking about what are we tracking deaths within the community? Like, is it really reflecting the true mortality in Lagos State? So the approach that we approach in Lagos, like I described, we have teams now at all the LGA level, and these teams involve the ward focal persons, the community informants, the LGA GSNOs. In short, we're using the polio structure within the each LGA to conduct this COVID response activities. And they're the ones going from house to house to do what we call active care search, as well as the health facility. We've developed the community case definition for this purpose, which has captured the basic signs and symptoms to ask for. And we're doing a retrospective kind of information, looking back about 4 weeks, trying to find out how many people have these kind of symptoms and have recovered, as well as if there's been any deaths recorded in the past 4 weeks. Even if we can't do postmortem, but those are being listed as probable. The data, the mortality data that I reported are only for the confirmed case. But if I'm to report probable mortality, of course, it's going to be higher than that. So that is the strategy that we're using to track deaths within the community that may be COVID related. Then I have, why do we have increased number of cases in an unknown LGA in Lagos State? Well, apart from the 20 LGA sample collection, accelerated sample collection sites, we also have what we call walk-in sites. We have 4 walk-in sites. We have one at the NIMA, which is the Nigerian Institute of Medical Research. We have one at Mainland Hospital. We have one at Luth and another one at Lassos, which are teaching hospitals where people can walk in to get their samples taken. And due to this stigma, we all know that in quotes, stigma related to these COVID activities, most people don't give their correct addresses or give details of their location. So this has accumulated into having a large number of positive cases that we can tag on our system belonging to a particular LGA, but we all know that they are within Lagos State. And that has that is what is the reason for a large number of confirmed cases in an unknown LGA in Lagos State. And in the issues of the health workers infection, and of course, we've recorded health workers deaths, mainly medical doctors. For us at NCDC, we have IPC guideline that's been developed for health workers, describing the minimum IPC measures that should be taken by health workers. And apart from that, we keep building capacity on IPC of health workers. So we developed another strategy to ensure that we train and retrain health workers on these IPC measures and emphasize the need to keep these IPC measures up to the standard, and also need to ensure provision of adequate PPEs. The minimum PPE that are required for health workers should be available at all health workers, at all health facilities. And this is being re-emphasized, and at the national level where necessary, we're supporting each facilities as much as possible. Also, there is a question, I don't know if it's for me, on resistance to our intervention. You know, by the time you carry the local health authorities and the local people involved, and you ensure that you build their leadership at the local level, they will tend to build more trust with your activities, build more trust with your response actions, as well as make it more receptive. And so at the local level, there's been we've not experienced any form of resistance in Lagos State because these local informants and the community informants and the work people that we're using for these activities are the people that are relating well with the local community people, and they know them well, they build trust over time, and this has been well accepted. And lastly, because of time, we're talking about the strategy used to mobilize additional human resources in Lagos State. I've mentioned that in one of my presentations. We leverage totally on polio structure that is on ground in Lagos State. The polio system infrastructure, all the real-time surveillance, the reporting systems that have been deployed in terms of ODK, in terms of SOMAS, in terms of ABADA, all these are the things that we've leveraged on. And also, we've also leveraged on the TB program. You know, this COVID response goes beyond what one program can achieve. So we pull in all other programs and all other activities within the health sector. So we're using the TB program, we're using the polio structure, and Lagos State also has developed what we call a volunteer corps, where those are health workers, different cadres of health workers, even medical students, can go online and register to volunteer and indicate the aspects which they will want to volunteer. This has also been very helpful to help us to change personnel over time so as not to get into a form of a burnout for health workers. Thank you. I hope I've been able to answer all the questions.
Well, thank you. You've really been able to answer all the questions. Thank you very much, all the panelists. Please, can you give them a virtual round of applause? Me, I'll clap from here because you can see me. So let's move to the next set of presentations. That was predominantly experiences from West Africa. And now let's have some experiences from East Africa intermingled within West Africa. We shall have Uganda, Cote d'Ivoire, and then Rwanda, and then we have a session for discussion. So this might take this opportunity to invite Lieutenant Colonel. It's not every day that you see a soldier being here, but I think COVID-19 requires that we bring all forces, including the security. So Lieutenant Colonel Dr. Chobe from the Ministry of Health in Uganda. Are you there, Henry? I can see we can see your slides, but we don't hear you. So unmute your microphone, please. Henry, we can't hear you. We can see your slides, but we can't hear. Your microphone is not, your microphone is muted. I can see it from here.
Ambrose, I'm sharing the screen for him. I think he has some connection problem.
But his microphone is not unmuted. It is still muted. I can see it from here. Henry, unmute your microphone, please. If we continue with the challenge from Henry, we might have to move to another presentation and we'll get Henry later because it seems you can't unmute your microphone. Echo, can you help to unmute his microphone from the host?
Yes, sir. I have tried, but his internet connectivity is very bad.
Okay, so I think we can't get the experience from Uganda now. Maybe the Ugandan colleagues, can you please try to resolve your connectivity? We shall move to the presentation of Cote d'Ivoire, and then we'll get Uganda later and Rwanda. So please, I would now like to request Dr. Kajo to present the experience from Cote d'Ivoire, and then in the interest of time, and then we'll get Uganda later. So colleagues from Cote d'Ivoire, if you can share your slides and unmute your microphone because I can see you here. Kajo. Echo, we seem to have a problem. So is it my connectivity? I've lost everybody.
No, it is not your connectivity. He's there, but I think he's not on his desk.
Henry, can you try to get back and get your slides again. Dr. Chobe. Cote d'Ivoire, please, are you ready to present, or you still have challenges? Because we need to move to the next presentation. We can do Rwanda if we can't get, Rwanda, are you ready to present? We seem to be having IT challenges with Uganda and Cote d'Ivoire.
Thank you, Ambrose.
I'm back.
Let's go ahead with who is speaking. I was saying, let's go ahead with the Rwanda presentation, please, because the Cote d'Ivoire and Uganda have connectivity challenges. So let's have Rwanda, please.
Thank you very much, Ambrose. Let me share this is Dr. Albert Wishime from Rwanda. Let me share my slides.
Yeah, Albert, you have the floor. Go to share screen, and you must have your PowerPoint open to see it. If it is closed, you will not share, it will not be. It has to be open, the presentation.
Yeah.
Fantastic. Put it in presentation mode, and then we are ready to go. Thanks a lot, Rwanda. Rwanda, over to you.
Well, thank you very much, Ambrose. First of all, it's a pleasure for us to be part of this webinar and be able to share our experience, but also learn from other colleagues. In Rwanda, in order to effectively respond to this COVID-19 pandemic, the first step was to develop a preparedness and response plan in order to guide our preparedness, early detection, but also early response to this pandemic. Our plan has got 6 overall objectives, with the first one to facilitate coordination and strengthen both inter and intra-sectoral coordination, engagement, but also partner participation. It's also targeting to enhance the national capacity for prevention, prompt detection, but also timely response. And the third objective is to raise the public awareness and engage the community. The fourth, to improve logistics management, to enhance operations support. And the fifth, to ensure the enforcement of safety and security measures. And finally, to mobilize required internal and external resources. So this is our guiding document. And in order to make sure we're implementing what is planned, the government of Rwanda has put in place a coordination structure from the national level, where we have the National Steering Committee under the leadership of our Prime Minister's office. And then down we have the Joint Task Force Coordination. And down again we have the Command Post, which is a structure to coordinate the implementation, the actual implementation on field. This Command Post brings on board different experts from different sectors. It's not only for the health sector, because our response is a multi-sector response. But also I have to mention that we have an expert advisory team bringing both public servants, partners, academicians, so that every intervention that we are planning or we are implementing is scientifically backed. Back to our command post, it has got four main cells or teams. The first one in charge of epidemiology operations, the second one in charge of administration and logistics, the third one in charge of communication, and lastly we have a cell or a team in charge of all the plans. So the goal for this coordination structure is to reinforce leadership, but also coordination capacities for our response to this pandemic. As of today, we have tested for 45,104 tests, and we had 287 confirmed cases, with the majority are men, as we've been seeing on in the other presentations, representing for us almost 80% of the confirmed cases, and women representing 20% of the confirmed cases. The majority of the confirmed cases, they are between 30 years to 39. And if you look at this trend with the number of cases, it looks like Rwanda has experienced two increases. When we looked at the second increase, which is around toward end April, we found that most of the new cases we are having, they are truck drivers on cross-borders itineraries. So the country has to draw specific interventions to respond to this new high-risk group or source of new cases. Because what I'm trying to explain here, if you compare this graph where we're having the total confirmed cases in orange, and we have active cases in red, and we have recovered cases in green. If we try to isolate those cases from truck drivers, this is how the graph becomes. So you can see it's a really a source of new cases of COVID-19, for which the country had to find appropriate measures in order to stop the spread of this infection. So what have we done? We've been working jointly with the sister countries in the region, in East African community, in order to see how we can ensure the mobility of goods, but also preventing the spread of this COVID-19. So among the prevention measures Rwanda has put in place, the first one was the decontamination of trucks, but also the country has set up temporary dry ports where incoming trucks could offload near the boats. If not possible, after the contamination of the truck, they could swap with the local drivers, so that the driver coming from out of the country can be kept near the border, but with every requirements available for him or her. For the trucks transiting through the country has put in place a measure of escorting those transiting trucks, so that they can, the country can make sure the transiting trucks do not really become a source of new COVID-19 infections. But also we have set up transit sites for truck drivers because we have to make sure they do have time to rest a bit, but also to have food or drinks on their way. And finally, we have set up a mechanism to implement the testing near the border. This was to respond to this new high-risk group, which is the truck drivers, but the country has not stopped there because we are now even targeting as hubs or other service provider points or companies which are really bringing many people seeking for their services. Talking about patient characteristics, so far as I said, we have 287 patients. More than 60%, they don't know if they have been in contact with confirmed cases. It's a point we have to explore more. More than 65%, actually 68.2%, they have travel history, which is obviously linked to that new high-risk group of truck drivers. But also, most of our patients have been seen with mild symptomatic. They were mild symptomatic patients, and only 30% they were symptomatic patients. And the number of days to recover in the treatment center varies between 14 days and 19 days. And the median is around 16 days before the patient is discharged from the treatment center. What have we learned, or what have we singled as enablers for an effective response to this pandemic? First of all, multi-sectoral coordination is key. You need to have different people on board from different sectors, from different expertise, so that the response they're putting in place or interventions, they really tackle different challenges or issues coming from different perspectives. For us, this aspect of command post has been really successful in terms of timely response to this pandemic. Secondly, we've learned that an effective surveillance will need or require an active involvement of the community and local government. Because once you have the population aware and well equipped in terms of knowledge, then both the contact tracing but also an effective quarantine becomes very easy. Thirdly, we need to identify in long time high-risk group. In our case, I've shared our experience with the truck drivers in cross-borders itineraries. Those high-risk groups, they are going to vary depending on countries, depending on the regions, but we need to make sure we are really aware of any source from those high-risk groups, any source of new COVID-19 infections. Fourth, the community surveillance through sentinel sites is essential because it's one of the interventions that guides or has guided our decisions in terms of implementing new interventions or lifting some of the ones we were implementing. So it has to be continuous, but also it has to be well implemented. Fifth, a decentralized capacity is required for a country, or for us, it has been really helpful in order to have our response across districts, being in terms of surveillance, in terms of detection, investigation, sample collection, or management of suspected cases. 6, an intensive public awareness and community engagement in innovative technologies is paramount, because a well-informed and equipped community is really a driver in order to contain the spread of this infection. In our case, in terms of innovative technologies, I can mention the introduction of drones in our community awareness, whereby pre-recorded information are uploaded in those drones, and they go around spreading that information around prevention of COVID-19. Finally, use of electronic data management system. And here we have to make sure we are getting information in real time for both surveillance, but also lab data, investigation, and case follow-up is an enabler to guide a rapid and guided or targeted response. With this, I thank you very much, and happy to respond to questions. Thank you.
Thank you very much, Dr. Albert. Albert, that's a very nice experience reaching from Rwanda. And now I'm told the Uganda presentation is going to be made, but not by Lieutenant Chobe, who is traveling. He's on the border with Uganda and Tanzania, so his internet is fluctuating. But somebody from the WHO country office, Dr. Alex Chimbaru, will present the Uganda presentation. So over to you, Uganda, for the presentation, and then we'll go to Cote d'Ivoire and we'll have a discussion. So Uganda's best practices, please, over to you, Uganda.
Thank you very much, Ambrose. Good afternoon, colleagues. It is unfortunate that Dr. Henry Chobe could not join us in this presentation. He's actually with the minister looking at the cross-border issues. So I am the deputy, I'm the co-chair of the IMT in Uganda. So I'll take you through this presentation. If I can go to the next slide. I'm sure the slides are controlled from that side. So if colleagues can help me to go to the next slide.
Bukari, can you move the slides, please? Bukari, the slides, you are controlling them from our side. Bukari, please.
Hello?
Move the slides.
No, I'm not the one who put the slide.
Okay. It is Henry. So let's check if Henry is on board, then we can let him run the slides. If he fails, then I'll continue the presentation.
No, but Bukari, you got the slides as a backup.
He has to. Hello?
We can see the slides. So Bukari move them and the presenter in Kampala will go ahead. So let's go ahead, please.
Henry, thank you very much, Bukari. Thank you, Ambrose. So if you look at the slide, it gives you the milestones of what transpired in Uganda since we had declaration of COVID as a public health emergency. So on the 15th of January, we had our Public Health Emergency Operations Center being activated with the incident management system into place. The country developed a preparedness and response plan on the 3rd of January. Then we commenced our airport screening in Entebbe on the 1st of February. We had the Interministerial Committee inaugurated on the 2nd of February to make sure that we have a close look at all the components of a COVID response, looking at the airport, looking in the country. So we brought in other players on board. Then between February and March, we had to do a capacity building activities for case management, IPC surveillance, and sample collection. Remember, this is a novel virus. That's the reason why we had to go for capacity building between February and March. On the 1st of March, we had to come up with a mandatory quarantine measures, focusing on travelers we had categorized as category 1. These are the cases we're reporting more than 100 cases per day, and that category was actually helpful for us identifying the at-risk populations. On the 18th of March, we came up with mandatory testing for all returning travelers. This now was actually beyond the high-risk category 1. So we opened up to all the travelers who were coming into the country which will actually experience COVID, despite the fact that you were in the high-risk category or not. Then this was also followed by closure of schools and suspended all public gatherings. Slide. On the 20th of March, the country come up with travel restrictions, which means that we were now looking at who is supposed to the country in Uganda, particularly those who are coming from category 1. Remember, I said these were reporting more than 100 cases per day. So having done that, we gave ourselves time to warn people who are coming into the country to indicate that we're going to be issuing these travel restrictions. So on the 21st of March, that's when we got our first case of EVD. This was identified at the point of entry. This actually led to the closure of the airports on the 24th of March. The only planes which were coming now were cargo planes. That's what was coming in. The country introduced a 14 days lockdown within the country. This applied to all people who were providing business who were within the country. So travel restrictions, lockdown meant that all the other people who were not included in the response, they were not supposed to be moving about, except for those who were supposed to be seeking for medical treatment. They were given that room. 10th of April, realizing that we picked a number of people at the airports and our neighbors were having also cases, we had to go for truck drivers mandatory testing. That is on the 10th of April. Then we also embarked on a rapid assessment survey to actually ascertain the existence of COVID in the communities. May to June, we are looking at the creation of our surveillance buffer zones, that is within the communities, within the border areas. Multi-sectoral collaboration was also established. Remember, that was one of our milestones, where we have our government of Uganda Interministerial Task Force, chaired by the Prime Minister, Unified Response Command between the Ministry of Health and Uganda People Defense Forces. Then, of course, we had bilateral cooperation East Africa Community Region with Kenya, South Sudan, Rwanda, and DRC. I'm sure those who have been participating in the EAC region, they actually appreciate why we had to be part of that. We have developmental partners who are supporting the response, and they've been very critical in this particular component. We have the World Health Organization, we have UNHCR, we have UNICEF, and of course we have bilateral cooperation with respective embassies. Let me point out that CDC is also one of the critical partners supporting government and working with UN agencies. We have a component of UN governments, non-governments who are actually on board, NGOs, private sector, telecom companies, Uganda Manufacturers Association, and of course, we have the private sector coming on board. The HE, or the president of Uganda, has been very instrumental in the fight against COVID. So as one of the social mobilization gurus, the presidential directives we came up with looked at the restriction of our mass gatherings, which included closure of schools, religious gatherings, weddings, and funerals. In terms of weddings, there was a restriction number of people who were supposed to be attending weddings. There's also a restriction of movement. Then, of course, suspension of public transport, mandatory wearing of face masks. This is a recent development, and of course, hygiene measures. In his speech as the president of Uganda, all these measures or these strategies are always outlined by the HE himself, which is a good drive to control COVID in Uganda. Slide. Right, so looking at our epidemic curve, if you look at the epidemic curve, our first case, we got this on the 25th of March. And if you look at the 21st of March, remember I said this was actually through the Entebbe airport. That is an airport-based case who was actually asymptomatic. So looking at the two issues, we have asymptomatic cases and then we have symptomatic cases. So the red ones are the symptomatic cases, then the blue ones are the asymptomatic cases. So the first one was a symptomatic case which was picked at the airport. So following that, we continued with our screening at the airport. So you see, that's why we picked most of the symptomatic cases, which you see in red from the 21st up to the 4th of April. These were picked through the point of entry. Then on the 11th of April, that's when we started our screening of our truck drivers, looking at the borders in our neighboring countries. We have Kenya, we have Rwanda, we have South Sudan. So we started screening in those particular countries. So if you look at it, all our screening at the points of entry, these were mostly asymptomatic cases. And today or yesterday, that's when you registered the highest number of our asymptomatic cases. This through cross-border, we had about 21 cases yesterday. The day before that, we had 13 cases. So as you can see, our numbers on asymptomatic cases are actually going up, and these are mostly picked from the points of entry. Slide. So we're to do a breakdown of our cases by nationality. The whole idea was to look at where are we picking most of our cases from. And you understand this has epidemiological implication, and most of the cases you are seeing here, they were picked from the borders, particularly the ones from Kenya, which is now leading in terms of picking our cases from the border. We have a total of 43, Tanzania 26, Burundi 3, and there was the China with 2, Canada 1, India 1, Eritrea 1, Rwandese 1. Then of course with one unknown who could not actually tell us with the origin. This was a data capturing challenge. Then of course Congolese and South Sudanese. So as you can see, our focus on the points of entry, we need to have more collaboration between Kenya and Tanzania. So this is just showing you the points of entry where we've actually picked most of our cases. So we have a border with South Sudan, that is namely, we picked about 17 cases. Border with Kenya, we picked about 36 cases. Then of course we have the other cases down there. Slide. Right, so if you look at our daily accumulated number of samples which are tested, you will realize that they are actually increasing by day. And this sudden increase, if you look at it, it actually started when we started having the points of entry testing. That's when we had our actual cases going up very high. So look at the first point, we have point of entry lab screening. That's where we started. And now cumulatively, we have done over 67,559 samples. This is the total number of our samples we've collected since we started looking at sample collection. So if you follow the line, it gives you the trend of where we are with each of collection of samples. So looking at the right-hand side scale, that's where we have the 67,000 mark. Those are the samples which have collected so far as a country. Right. The country, realizing all these problems, we were now wondering whether we have a problem, a transmission in Uganda or not. Remember, we're talking about truck drivers. Then we had about 4 or so cases which we could not account for. That's the reason why the country decided to go for a rapid assessment survey, but realized that we're focusing in those areas where we also have the highway routes, which are high-risk routes. So the goal of this is to find cases that are not caught by the route screening and testing and are therefore circulating to communities around them. So the objectives of the rapid assessment was to establish the presence or absence of community transmission of COVID-19 in Uganda. So we also try to identify population subgroups at high risk of COVID and their geographical locations. Then to compare the performance of various diagnostic test kits, sample types, look at RDTs, the molecular test, and the sample test, which we thought we were looking at the swab, saliva, and blood. So this was the focus of the survey. So far, the target for the survey was 23,414 samples, and so far 18,082 people have been enrolled. Out of this, 18,059 samples have been collected, and the laboratories have actually received 15,000, tested 14,061, which means we still have a backlog as far as testing of these samples are concerned. So the green marked areas, this is where we've been collecting most of our samples as a country. So the numbers are indicated where these samples were collected from in each particular district. So you realize that interviews have been done on those about 18,000 people. Some of them samples are still to be collected. So from the survey which was done, the preliminary findings right now is that we have 4 confirmed positive cases, and with no epidemiological link with a prior case, which becomes a challenge as a country. So we're now looking at the overall community transmission, where we're looking at a proportion of positivity of 0.028, which is about 4 out of the 14,000 samples which have been analyzed right now. So what we're simply saying in this particular case is that we have a sporadic case distribution in Uganda in those areas where these samples were picked. We still need to find out the epidemiological links, and investigations are ongoing. So if you look at the map on the left, we have Masindi, a sample was picked, then we have Rakai and Chotera. That's where the samples were picked. So geographically, that's Rakai and Chotera. One of them is supposed to be Chotera, not Rakai. So Rakai and Chotera. Thank you. So just a summary of the findings is that we look at Chotera. There were two samples which were picked from Chotera, and the hypothesized value of that was 0.1. And if you look at that now, the value is 0.3. Then if you look at Rakai, we picked 1 sample, and the hypothesized value was 0.1, and what we have is 0.34. So going to Masindi, the hypothesized value was 0.1 according to the researchers, and we have it at 0.3. So the population subgroups, we're looking at law enforcement officers. This includes those who are working on the highway, who are monitoring the vehicles. And then we also have a border crossing point. Then we have a community households, which we are looking at. So this is the picture right now in terms of our findings of the survey, which was conducted in Uganda. So we are saying in terms of our community alerts, we had 0 on the community alerts, where we could pick the positive cases. Then of course, our positivity right now on the rapid assessment is standing at 0.028, which is about 4 out of the 14,000 samples which were collected. So looking at the bulk of our cases, the questions which we asked ourselves was, do we have important
Alex,
cases?
you need to be winding up in the interest of time. Alex, you need to be summarizing.
Thank you very much. So please, next slide, so that I can skip this one. So what you're saying is that our imported cases is what we have right there. That is about 93% of our cases right now are imported. Next slide. So we came up with a system of managing imported cases where we are saying the 141, some of them were returning travelers, and of course we pick them through the survey, and illegal entry becomes a challenge. Illegal entry is focusing on the points of entry. We have illegal points of entry bordering with the countries I've already pointed out. Then of course we are also having these cases being distributed over the truck drivers. So for the airport, we picked about 99 cases, that is in March. Then we also picked 33 people from quarantine. These were quarantines, were also travelers who were put in quarantine, we picked at the airport. Next slide. So focusing on our regional efforts, we have East Africa Heads of State Consultative Meeting on COVID, which were attended by the various ministers to discuss issues of cross-border. Unfortunately, Tanzania and Burundi were not able to join that. And we also have joint consultative meetings to come up with joint positions, that is by the ministers, Minister of Trade, and Minister of Transport, to come up with very specific positions as far as cross-border is concerned. We've had bilateral ministerial engagements with Kenya, South Sudan, and Rwanda. With South Sudan, we've had teleconferences, Zoom meetings. With Kenya, we've been exchanging information. We still need to do that with Rwanda. Of course, we've also had joint meetings of ESA ministers, which have been taking place to come up with common positions, common procedures as far as cross-border is concerned. Next slide. So our current focus right now is look at enhanced surveillance at border points. I've already mentioned about issues of engagement with our colleagues. We are looking at the creation of Basel zone of intensified active surveillance, where we are actually going to be monitoring activities between the borders. We intend to expand laboratory testing capacity. Our challenge on that has been that our slides, our results were coming in a little bit late. Then, of course, community engagement in the points of entry, that is another area which we think is very important for us to win issues of our cross-border collaboration, particularly where you have illegal entries. Then we've also come up with a decentralized response with district strengthening, focusing on the cross-border activities. So in conclusion, we're saying that the early activation of the task force for outbreak response was actually helped to escalate coordination responsibilities. Early development of the national scenario-based response plan also was a positive in coming up with the evolving outbreak and coming up with the modeling. Then, of course, decentralized response at the district level and the cross-border level was actually a plus for us as a country to pick the various positive cases from our truck drivers. So the unified response with the Ministry of Health and the uniformed forces is actually a positive response, because we actually helped to implement points of entry monitoring and also looking at the illegal crossing point. So in summary, this is what is coming from Uganda. Thank you.
Thank you very much, Alex, Dr. Alex Chimbaru, for stepping in for Dr. Bwire, who is in the field and had no internet access. So we will go to the final presentation. So Dr. Kajo, now I hope you're ready to present from Cote d'Ivoire, and then we'll have a Q&A session before we do our last two best practices from South Africa and Angola. So Cote d'Ivoire, please, Dr. Kajo, you have the floor.
Oui, allô, vous m'entendez? Allô?
C'est bon.
Allô? C'est bon?
Oui, c'est bon.
Ok, d'accord. Donc, merci. Je vais donner ma présentation en français. Les diapos sont en anglais, donc je présenterai en français.
In English, and I will do this in French. Thank you for
particulièrement des activités du laboratoire dans le cadre de la réponse au COVID-19. Alors, ma présentation s'articulera comme suit: une brève présentation, un background, une brève présentation de l'Institut Pasteur, les actions entreprises par le laboratoire pour le diagnostic du COVID-19, la stratégie nationale, quelques mots sur la stratégie nationale du diagnostic, et les défis, et ensuite je terminerai par une conclusion. Alors, comme vous le savez, le monde fait face actuellement à une épidémie, donc une pandémie majeure, et compte tenu des caractéristiques donc, de la pathologie, de l'agent pathogène en cours, le laboratoire doit jouer un rôle essentiel dans la confirmation du diagnostic. Alors, des questions essentielles se posent, c'est-à-dire comment répondre donc pour le laboratoire.
How to respond to the diagnostic request in an epidemic, in the context of the pandemic. What strategy should be put in place, be implemented with regards to the objective for us to reach 3,500 tests per day? What tests?
Et où réaliser les tests. Alors, c'est à ces questions-là que nous allons essayer de répondre à travers cette...
Fielding answers or attempting to answer during the brief presentation that I will do now. Now, talking about Institut Pasteur of Côte d'Ivoire, it is organized this way. Its specific characteristics is that in its departments, you have laboratories. In a number of departments, you have WHO reference laboratories, the WHO intercountry lab. We have the unit of nervous system. We have one for measles, and there's a national WHO National Center for Influenza. We have one for nervous system. We have the intercountry polio lab. Those quote just major ones, and you can see the key role that was played by these WHO reference laboratories, without which at the beginning of this pandemic, this outbreak, we really would not have been able to provide any rapid responses. They played a key and essential role in the first initiatives that we carried out. From the beginning of the pandemic, what did we do? As a team in Côte d'Ivoire, we quickly put in place a laboratory team. A laboratory team made up of biologists, 12 in number, technicians, logisticians, database managers, equipment maintainers, secretaries, hygiene and waste managers. This laboratory team was the human resources of the department for the management against it at Institut Pasteur, and we had to come up with a response. The team was trained in terms of biosecurity, how to propagate, how to handle equipment, how to dispose of PPE, how to manage samples safely, and how to, they were also trained in performing molecular tests, and we also have protocols for the various data management training that was done. These are teams that were put in place not only to respond to the requests for diagnosis, but also to continue routine activities, because we needed to continue surveillance activities without interrupting them because of the pandemic. Now, the second activity which was carried out was, as you do know, from the start, we really did not have capacity to carry out any diagnosis because we did not have the information. And so there was a training organized by CDC Africa in Senegal. When we got back from that training, we quickly put in place a diagnosis, validated PCR protocols. We put a number of platforms and the department and in the molecular biology platform. The aim of this was to use these platforms in case or in the event we were overtaken by excess demand. Now, once that protocol was put in place, we quickly responded to demand for samples that were sent by the EPI team. So I must say that all the samples that were sent for these, that is from the National Institute for Hygiene, all the samples were tested by PCR at the laboratory. And so there was the definition of cases that was done, but we must say that we don't get involved in the definition of case definitions, but we just receive the samples and we do the analysis. We could give some advice, but the rest was to be done by the laboratory. And I must say that until this day, we've not run out of, run short of analysis since the beginning of the pandemic. Now, in terms of the strategy for tests, I must say that the Institut Pasteur Laboratory was the first to take up the job. We are the first to be involved in the diagnosis. The state took the decision to decentralize diagnosis activities to Abidjan, but also in the country by relying on laboratory and university reference hospitals in the country. And these gene experts, they are certainly served with this number of reagents to do the diagnosis. We have other laboratories which also have equipment. And so it is these that were at work, but there was no real procurement of equipment, but we just carried out this decentralization. And we must note that the said decentralization was done by Prime Minister's order, entrusting the responsibility of this decentralization to Institut Pasteur. And so Institut Pasteur within the strategy, this strategy is in charge of training staff from the various laboratories that are operating, and also to centralize all that has to do with orders for all reagents and molecular, and make these available to these laboratories. A few was talking about PCR tests, but besides those, we also intend to use rapid sensological tests, and we also have for these tests that are being done at the Institut Pasteur in Côte d'Ivoire. For results, we must say that the only laboratory doing the tests so far has been able to, or at least until yesterday, 15,599 samples tested, between 400 and 500 samples per day. And we have confirmed cases 1,971. And the time between receipt of samples and reporting of results is less than 24 hours. Anyway, we should note that since we launched the opening of these laboratories, we've been, since last week, are opening new testing centers in country, in Abidjan and within the country, to facilitate the movement of peoples. And may I add that people go into hospitals and they are saturated. But since the opening of these centers, the laboratory is overwhelmed. But this challenge is related to the fact that the other laboratories that were supposed to work alongside Institut Pasteur are not yet operational on account of the fact that the supplies we ordered, have not yet been delivered. And that is one of the major problems that we have, because for all the reactives, we depend entirely from abroad. All these have been ordered, and but it's delaying. However, 2 laboratories besides Institut Pasteur will be operational as from Wednesday. And from Wednesday, there will be another laboratory which would be opened in Abidjan, and another one in the hinterlands of the country. That would enable us to reach 2,000 to 3,000 samples, which was the target set. What are the lessons learned? We must say that we've not learned enough from previous epidemics, such as Ebola. We've had to fix shortages, shortcomings, which we could have avoided. Unfortunately, we are suffering from that. And unfortunately, the fact that we did not draft an emergency plan, a plan that would enable us to have a proper assessment or evaluation of shortcomings in the laboratory or limitations. I think that it's important for all countries to have in their laboratories an emergency plan, a preparedness plan to handle crisis. Such plan would enable us to really assess needs in the laboratories. And from this evaluation, we should be able to come up with a number of criticisms. That is, maybe a PCR apparatus may be able to help you. You may lack one tube or one reactive. You cannot do the entire test. So every link in the chain for analysis should be available, because if one is missing, then the entire process would not be able to work. And maybe we really laid emphasis on automation, but we could not do evaluation. But if that is missing, we will not be able to do the analysis as we want to do. And to manage a crisis of this kind, we should have a good leader. Each one does not have the same objectives. Each one does not have the same capacities in crisis management. We really need to have a good leader, a good manager, to be able to take care of each one and in the light of the objectives and the interests of each one's various stakeholders in the framework of the crisis. That is what I thought I should say so far regarding what we have put in place in Côte d'Ivoire. Thank you.
Merci beaucoup, Dr. Kajo.
Thank you very much, Dr. Kajo.
I think we have reached the Q&A for these 3 sessions, and I would love, we had Uganda, we had Rwanda, Uganda, and Côte d'Ivoire. Bukare, can you summarize the questions for Côte d'Ivoire from the presentation? Because I can see questions from Aikipe and Jampini and Ibrahim Atali. So if you can summarize the questions, and then I'll go to Uganda and Rwanda. Bukare, over to you to summarize the questions for Dr. Kajo.
Yeah, the question is for Côte d'Ivoire is they're asking why there is no psychologist, anthropologist among the team. How do you ensure the psychosocial support? It is all.
There is also a question for Côte d'Ivoire on if you are planning to do decentralization with gene expert, what are the key safety considerations you are making? But there is also a question in the Bukare, if you could read the question in the chat room from Gampini Drin for Côte d'Ivoire. You've seen it?
No, I'm not seeing.
Jampini avec no testé. Okay, I'll get it. For you, Rwanda, thank you. The question several for you. What preventive measures have you put in place for truck drivers? And then with respect to, could you describe the driver's swap mechanism? And the third issue is, have you experienced anything with forced or voluntary returnees? And then what are the sources of infections? Do you have any clue about the sources of infection among the drivers? And what are you doing towards a regional approach for this? And then how do you mitigate truck drivers stopping at secondary homes? Uganda, you have several. What is the strategy for travelers coming to Uganda? No, for travelers coming into Uganda when airports are reopened. What is the regional approach you have put in place? And can you comment about the bilateral relationships between Uganda and your southern neighbor, Tanzania, in the context of the East African community? And then Uganda and Rwanda compared, looks like you have cases that are coming from outside. Is there a possibility of duplication of cases? And so this could also be a duplication of cases at the Afro level. And then there is a question from Nesta on what you think is the role of past outbreaks in the response interventions you have had, labs, IDSR in Uganda. What is the average turnaround time for laboratory results in Uganda? And then for both countries, Uganda and Rwanda, what specific challenges have you experienced as landlocked countries? Those are what I captured. So we'll start from the colleague from Côte d'Ivoire and then Rwanda, and then we end with Uganda. So Côte d'Ivoire, please respond to your questions.
Concernant la première question sur
now, on the first question regarding the team and who they have, well, I was talking about teams only at the laboratory, teams in charge of doing the molecular tests. I really did not talk about the entire team members. In the country, we have sociologists, anthropologists, that are part of the management of this team, of this crisis. But I only focused on the team that was in the laboratory. That's why I did not mention those. Now, the second question had to do with the young tester. We decided to use platforms for tuberculosis. There are laboratories which are spread across the nation, and these laboratories have technical platforms, and that's not the best strategy with these expert genes. It's not the best in processing the samples. That is not the ideal tool. But internationally, we have cassettes for diagnosis, and that is not obvious. But we are committed on this, and I think that very quickly we have these laboratories would have PCR laboratories to do the tests in turnaround time that is good. Thank you very much. I think I responded to both questions, okay?
Yeah, thank you very much. Thank you very much. So let's, Albert, please, can you take on your question from Rwanda, and then Alex finally, and then we move to the final set of 2 countries. Albert from Rwanda, please. And Cote d'Ivoire, if you could stop sharing your slides, that would be very good.
Thank you very much. The first question on preventive measures for truck drivers. We are implementing both the same measures as for the general population, social distancing, hand washing, and facial masks. But also we're encouraging to limit the interaction between the truck drivers with the rest of the community, where they are coming from or where they are heading to, respecting the country's protocols. For the second of having dry ports near the borders, where incoming trucks can swap drivers with the incoming driver staying near that port, and the other driver coming in country, taking the truck to the final destination, in order to avoid importing or exporting new COVID-19 infections. But in that process, we ensure everyone got what is needed, but also respecting the national prevention measures. The third question was around forced voluntary returnees. Whoever is coming in country is treated according to the national guidelines. So as of today, borders are closed, but whoever crosses our borders has to abide to the guidelines and protocols in place. The next question was around the source of infection for truck drivers. It's a point which is being further explored, but you can't exclude, or one of the assumptions is that promiscuity and contact with different groups of people, where they are coming from or where they're heading to. But this is a point which is being explored further. The next question was around regional approach. Yes, regional approach is essential. For example, for countries where movement of goods has to continue, so regional approach has to be really implemented or encouraged in terms of harmonizing preventive interventions, protocols, tools, and sharing information. The next question was around second home. So for truck drivers, as I said, we whoever is coming in the country has to abide to the national guidelines and protocols before he's sent back to his or her home. For the question around duplication of cases, in Rwanda, whoever is tested positive is taken to treatment centers, and this is reported in our national daily report. So I can guarantee you, whoever is tested positive is part of the report we are issuing every day. So I think those are the questions that were asked to me. Thank you.
Thank you very much, Albert. Over to you, Alex, for your final comments on the questions.
Okay, thank you very much, Ambrose. Thank you very much, colleagues. I'll start with the one on the duplication of cases. There is that very high possibility of duplication of cases across our borders. But what we've been doing on our side is when you get information, say, from South Sudan, of a positive case, they are admitted in our referral hospitals, but we do not put them on our line listing. What we're doing is manage the cases, but we don't put them on the line listing to prevent duplication of cases. On the role of previous outbreaks, yes, there's been a very good role of previous outbreaks. If you look at IDSR, it brings in the component of surveillance, component of investigations, component of outbreak management. If you look at EVD, actually similar to what is happening right now. During EVD, remember, we're to set up screening at the points of entry, and those facilities are still being used right now. We are talking about a collection of samples, which is also happening during EVD, using that particular experience. That is also happening right now. So we've actually used experiences from EVD, from IDSR, to manage our current outbreak, including the setting up of the coordination mechanism. So I think there were lessons learned from EVD, which we are using right now. On the turnaround time for the points of entry, that is a challenge which we have faced over the weeks. We could have a turnaround time of 3 to 5 days. It's only this week that we started seeing an improvement of 24 to 48 hours because we've actually opened additional laboratories to address to that. Challenges related to our current operations at the points of entry. The biggest challenge we're having right now is the issue of collection of samples in a very fast way. We are at times creating congestion because we have long queues. Our people are at times overwhelmed, but we have actually increased the number of people operating at the points of entry so that we reduce on the issues of overcrowding. That's one point. The second point we're facing at the points of entry is inaccurate information from the drivers. They give you wrong numbers for the vehicles, they give you wrong numbers even for the phone numbers. So which becomes a challenge. This has been noted that they are giving false numbers. So we've devised a system whereby the security details actually verify the numbers of the various vehicles passing through the points of entry. The other challenge we've had is monitoring of drivers along the highway when they get into Uganda, going to South Sudan. We've actually established designated points, but these are not yet fully functional. So resulting in these drivers stopping all over the place, which might actually result in transmission. So we're coming up with mechanisms of managing that. Information sharing across borders, we have not been very strong. That's an area which we're operating right now. We've started with South Sudan. We've done that with Kenya. Our next move is to look at Rwanda, Tanzania, and possibly DRC. So the last one is when you open the airport, what is the strategy? The strategy is not going to change. Our strategy is about testing, identifying 6 people, isolate them, put them in quarantine, then we discharge them. So the current measures we're applying right now, we are not going to suspend them if we happen to open the airport. So we continue the same measures. Operationalizing of the cross-border, we are looking at it in 2 levels. That is the national level where we actually communicate with incident managers in the other countries. Then we're also looking at the cross-border collaboration, direct points of entry, cross-border collaboration by the operatives in these particular areas. So we are yet to develop cohesive standard operational procedures for COVID. We have the ones for EVD, which are going to adopt. Thank you.
Thank you very much, Alex. And again, we really need to congratulate the 3 panelists from Cote d'Ivoire, Rwanda, and Uganda. Now we are going to the final 2 best practices. And now we move to the southern part of the continent. And this is the experience of our colleagues from South Africa and Angola. And so we'll start off with Professor Koleka, and then we go to Dr. Mufinda so over to you, our colleagues from South Africa, and you have quite a wealth of experience that I think the continent wants to learn about. Over.
Good afternoon, everybody. I hope everyone can hear me well. So my name is Koleka Mlisana, and I am with the National Health Laboratory Service. And thank you for actually inviting us to just share some of our experiences. And I must say, it really has been a great afternoon just listening to colleagues' experiences, and one has learned a lot. So I want to say that I really have tried to limit my presentation specifically to just looking at the wide-scale laboratory testing, and I'm going to try and see if I can really stick to the 10 minutes that I was given. So if one just looks at our country, this is the current status as of the 14th, where we're sitting at a total confirmed cases of 12,739. We have performed just over 400,000 tests. This was 2 days ago. And I know that yesterday we had another 18,500. So we're sitting at just above 420,000 tests that we have done. And this just shows you where the cases are. And just to note, the Western Cape has got the highest number of cases, and we're still just struggling to understand why that is so. And this is followed by Gauteng, which is the hub really, of the economy of the country, and then followed by the Eastern Cape and KwaZulu-Natal. So what actually happened in our
Professor
country—
Koleka, can you put your presentation in, your PowerPoint in presentation mode so that we can see the full screen?
Just please click on display settings and then duplicate.
Sorry, come again?
Click on display settings on the top, on the middle one, the left one. Sorry, middle one, display settings.
Yes.
Yes, click on that and duplicate select you.
Oh, okay, sorry. Thank you for that. I learned something new. Okay, so what happened is that this was, when the epidemic started in the country. Obviously, these early days, it was mainly from outside, infections associated with travel. And then we initiated the lockdown quite early in the epidemic. And this slide was actually presented by Professor Abdul Karim, and he presented this to the nation because the Minister of Health has established a ministerial advisory committee, of which Slim is the chair. So he presented this to the nation, where we were saying we're about 2-3 weeks into the lockdown then. And the question was, what is the plan for the country and what needs to happen next? And the point that he made was that really during the lockdown, we need to make sure that, we get to what we then call stage 4, which was active case finding. And so that we can be able to identify hotspots. And what it therefore meant was that, in fact, he used this slide as an example where he's saying we need to identify the small fires, where the infections are, so we can get an understanding of where are we seeing the infections, because by then we had realized that we do have a community transmission already, and make sure that once we identify those, we're able to take those fires out before they become wildfires. And what this therefore meant was that we need to get into community screening and testing, massive community screening and testing. And that meant for us as the laboratory that we needed to ramp up the lab testing. So what then we did, this slide is a bit busy, but I thought I needed to condense everything into one slide. So the country is that with the National Laboratory Health Service provides pathology testing to almost 80% of the country. And this is really just the footprint across the country, you can see. And this sort of mirrors the healthcare facilities in the country. And so for testing within NHLS, because we've got this massive, HIV and TB program, we then realized that we could actually use whatever residual capacity that we have from the viral load high throughput platforms that are in the country, the gene experts that are actually decentralized across the country. And then we needed to understand what other open, PCR platforms are available. within the NHLS platform. And coupled with that, we actually made available 67 mobile units, some of which are actually fitted with expert instruments. Because the rationale was, if we're getting into community testing, then we should actually be doing the mobile testing, at that time. And then the NPG, actually the large group of the private pathology sector, and this we had to come, they had to come on board. We basically need to understand what is the capacity within the country. And so we then knew that for NHLS, actually given the platforms that we have, we could actually ramp the testing up to as high as 30,000 testing per day. And the National Pathology Group have also come and said, we also as a private sector within the country, if everything else is normal, we can go up as high as 10, 15,000 tests per day. And what also has happened is that now the medical schools with their research units and academic units, they also have come on board, and they've actually formed a consortium where they have said, as the academic, as academics within health sciences, we actually have got these platforms, and we've got scientists on these platforms, and therefore are available to assist with any surge testing that the country might require. And we have engaged them, and we actually have got service level agreements that we're actually engaging them with, and who are then looking at each lab, and I'll show you how we are doing this, and making sure that the labs are ready, and then they can start and assist with testing. And the other advantage that we have is that even all these other research units, like the CSIR and the Agricultural Research Council, they also have said, we have got the expertise, we can therefore do testing. And even business, because obviously there's a huge mining industry within the country, they have come on board. And I think really the point I'm making here is that everybody realizes that it's important for us to make sure that we are ready for the ramping up of testing. Because the question is, what are we expecting as a country? What's the numbers that we're looking at? And I don't think we have managed to actually fine tune. People keep saying, are we looking at 60,000 tests a day? Are we looking at up to 80,000 or not? But what we have been doing from the laboratory testing perspective is to then make sure that we gear ourselves up, and any other lab that actually wants to come in with a testing platform, we have come on board. So what we have done is that everyone who says, I've got the expertise, this might not be showing very well, sorry about that, I've got the expertise, then we have developed this Ready Lab COVID app, which every other laboratory then completes. It just gives us a sense of who is ready to, to start testing, who would actually require, some level of training or whatever support before we can say, yes, you are ready. So everyone who wants to assist with the surge testing, they complete this tool, and then after that, then each lab that has submitted goes through a quality assurance assessment where we're able to see who actually have got accreditation, who are actually appropriately registered, or who actually still needs help insofar as that is concerned. And then they go through these steps, and then once that is done, obviously then there are service level agreements that have to be done, and then the lab is ready, and then there's communication with the NHLS, because the samples from the public are coming to the NHLS, and then each local NHLS lab would negotiate or would actually come into an agreement of how the flow of samples will go. So we are still in progress with this, and there really has just been excellent support from everybody. Now, this just shows the scale, the testing scale up, in the last few weeks. And as you can see, this was at the beginning of the epidemic, and this would have been around the time that Slim made that presentation. And we're anticipating this surge, in testing. Right now, last week we were doing about 97,000 tests per week. And if you're looking at daily average per week, we're sitting at about 15,500. Like I said yesterday, I know we actually did 18,500 tests. So I've already told you how far we are, the total testing that we have done. So coupled with that, and the reason why there was such a high, ramp up of testing, it was because of the community screening and testing. Because then the issue was, if we need to identify this, we need to then go door to door. So there have been more than 40,000 healthcare workers, community health workers, who are going door to door, and there's actually a screening symptoms, and anybody who's got those symptoms gets referred for testing. And this just shows us the numbers. I mean, if you're looking at the total here, we've already done 10 million screens, since the screening, the CST started, and 119,000 of those have been referred for testing. And this is one of the reasons that really just caused a huge ramp up. And you can see that in some provinces, actually, there's a lot of testing, 2.6 million done in one of the provinces to only yield 0.14%. So there are, positives and negatives with this. And in fact, it came to a point where we realized that there are lots of challenges, and I'll come to that, with this massive screening and testing. So, but at the same time, I just took one province that can show us how the ramp up in laboratory testing has assisted with community transmission. Because now in the Western Cape, with the testing that has been happening, they've actually been able to identify some of the hotspots. And the good thing about the Western Cape right now, they have got the highest numbers, like I showed you, more than 7,000 cases. And when you're looking at their positivity rates, they are much higher than anybody else in the country. They're sitting at around between 14 and 15%. And what that says to us is that they are probably doing proper targeted, testing, in that they are able to follow contacts, and they're able to pick up those contacts, which is why they have managed now to actually create these hotspots. And then it makes management thereof a lot easier, because then you can come in, zoom in within them, try to understand why are these hotspots there, and focus on those. So really the ramping up of the testing has actually given us an answer in identifying the hotspots, and it therefore then changes the way that we manage the epidemic, because it means we need to then focus on the hotspots. So what are the challenges and the lessons that we have learned? I think the first thing was for us to do the in-country capacity, just to see what capacity have we got for PCR testing. And if you look at what we have, there is actually adequate capacity. Obviously, there are a few instruments that we needed to have, specifically as NHLS, more to enhance what was already at hand. But the one thing that we really, though we knew it was likely to happen, but I don't think we really anticipated it, and it is what is hitting us at the moment, is actually access to kits and reagents. Because, I mean, for us as a country to ramp up into doing 18,000 PCRs in a day, now competing, for access, competing with the rest of the world, we really are having a huge challenges. Even though we've got a broad spectrum of platforms, whether they are closed, the ones that are high throughput, or the open platforms, but the other biggest challenge has also been with the extraction, RNA extraction, because for those that are open access, you then also need to have extraction kits, and we really have struggled, to get those. As a result of this, we now are seeing, unfortunately, backlogs as a huge challenge. I know somebody actually was saying, earlier on in the presentations, that we really are aiming to have, results within 12 to 24 hours. And I must say, for us, for most of the times, we are not able to meet that because of the kits and the reagents. And that's one area where we really need to see how we then unlock that. As a result, now we're looking at getting, automated extractors, or also looking at alternatives rather than RNA extraction. And so, and in fact, I enjoyed the pooling, the pooling concept, in that we also have said, let the labs explore whether pooling can be done. Though sometimes using the pooling mechanism might be a bit difficult, especially in a high throughput lab. So labs just need to explore that and see how they would introduce that, because obviously will bring in a lot of, we'll be able to get to do a lot more tests, especially where we can identify provinces that have got low positivity rates. And also the fact that now everybody has come on board, and I mean, even including, private sector, that is, the industry. So we're able to share with the private pathology labs, share kits, and as well assist each other with the backlog. And really the burden that we have received with the massive, screening, and sometimes we realize that the provinces were not doing the symptom screening as they were supposed to. It really has just caused the system to struggle quite a bit. As a result, now we're in the process of reviewing our testing strategy, where we want to look at targeted screening and then doing prioritized testing, where we're going to say anybody who's in hospital or admitted, healthcare workers who are exposed, and then we look at the contacts of those that are positive, and we prioritize those. And then we move on to focusing only really on the hotspots. And the last but not the least is the fact that, as the joint academic labs together with NHLS and the MRC, we're able to submit joint application. Let me end there. Thank you.
Thank you very much, Professor Kolela, for a very comprehensive presentation. There are a couple of questions in the Q&A that I'll summarize for you at the end of the session. Now we're coming to our final, but not by no means the least, because Angola has quite a wealth of experience in beginning to relax some of these measures, and Professor Dr. Mufinda is going to share this with us. So over to you, colleagues from Angola, and share your experience, and then we can have a final Q&A. If you can share your slides. Bukari, did you get the slides in advance?
No, they are going to share. They will share them.
So you have the right to share now, Dr. Mufinda. We can see you and in your office in Luanda.
Unmute yourself, please.
Faz favor, já está?
Thank you. I'm ready to go.
Já está?
Please go ahead. We are hearing you.
Thank you very much. I would like to acknowledge the presence of the Minister of Health of Angola together with me. Dr. Gaviera Rambula is a WHO representative in the country. And I wish to state that Angola has got more than 30 million inhabitants. We have got 18 provinces. Up to now, we have registered 48 cases, positive cases, among which 2 deaths, 14 recoveries, and 32 active cases that are under clinical care and are stable. And we would like to indicate that the male sex is the most affected, because the majority in terms of percentage are males. At the age of the patients, we have from 20 to 59 years, which is equivalent to 70%, and 85% of the patients are asymptomatic. Also, we would like to inform that 62% of the 48 cases were imported cases. COVID history in Angola started with imported cases from Europe, and we can name America, Europe, and Africa from where cases were imported. Now, in testing, we use GenExpert and PCR testing. Luanda is the epicenter where we have all the cases. We have no cases in the other 17 provinces. We are in the stage 4 of the lockdown, and I will explain this later. Our timeline. We started with the WHO declaration of emergency of public health. Since then, our country in the 30th of January, we came up with an interministerial committee headed by the President of the Republic. We also came up with our national contingency plan, which has got 4 main pillars, which include logistic, epidemiological surveillance, communication, and case management. And all these sectors are included in this plan. We meet on a daily basis in order to assess the situation in all the country. On the 4th of February, we had quarantine, institutional quarantine for passengers coming from China, and these were going on mandatory institutional quarantine. And this quarantine was also extended to countries who had community infection. Other than China, we also added Iran, South Korea, and Italy. Those are the 4 countries which would go for mandatory quarantine. We had capacity building in management, case management, with the support of the WHO. WHO has been with us since the elaboration of a national mitigation plan. On the 12th of February, we also had the capacity building on case management. On the 10th of March, we had the capacity building on lab capacity within the country, from which we learned about the use of RT-PCR testing in Angola. Now we also use Gene Expert using the resources that we have from the PB program. I would like to indicate that the first suspect case, the samples were taken to South Africa, but since March, we started carrying out our testing internally. On the 17th of March, we implemented other activity, including institutional quarantine, in which all passengers coming from countries with community infection, we added other countries apart from the initial 4. On the 21st of March, passengers coming from Portugal, from people coming from Portugal, we isolate 2 main initial cases from Angola. Since then, we closed our borders with neighboring countries in order to manage the spread of the pandemic in the country. We increased activity of active SAGE, and we also trained our personnel for migration, our ports and airports. These are a number of trainings that were carried out also throughout the time. We also engaged in the purchasing of medications and PPEs, and we also started a joint activities together with the police in the identification of suspected cases, as well as in spreading information among population. And these structures help us in spreading information among the population in order to present themselves in the health facility in case of symptom. On the 25th of March, we had the state of emergency declared by the head of the state. We also installed testing camps in the ports and the airports after the state of emergency. And also there was a closure of public gatherings, and on the 25th of March also other measures were added. This is when we started to mobilize 3,000 hospital beds for moderate cases. And we also added 600 hospital beds for intensive care patients. On the 14th of April, other measures were brought about with the assistance of the WHO. We also used the measurement of respiratory acute respiratory infection as a measurement. And on 27th April, we had the first local transmission case. Therefore, we had to increase our measures, preventive measures among the community. On the 30th of April, we increased our lab capacity. The country, till 17 April, we had only one lab, and we added 2 more to 3. We used other equipment, and we had 1 lab in the military hospital and in Stiga. And we added gene experts in order to increase our testing capacity. This is the timeline that we followed in our COVID measures. What we did in general, in terms of organization, we established the multi-sectoral committee that was headed by the president. We came with our contingency plan, and in all our activities, civil society is involved, and we control the health and the socioeconomic indicators. We have to control because most part of our population lives below the poverty line. So we have to come up with other measures of assistance. We also establish normative protocols with the assistance of the WHO, and we implement our operative centers, and these are included in our contingency plan. We also had cooperation with the WHO. They provided us test kits. Our testing only started with the assistance of the WHO. They also helped us with PPI and other materials. And we also did our part, but we cannot forsake the help that we got from our partners. In terms of the rapid response related to the uncertainty, we can say that the restrictions that we came up with helped us in reducing the possibility of contamination and spread of the virus in Angola. These were added to other measures such as hand washing, laser temperature measurements, and mask use. And this is what brought us to the situation where we are today. We also came up with other measures. If we identify one case, we also have to create measures and in order to control the spread of the disease. We also say these measures also affected us economically, and because we had to close all our economic activity after the state of the emergency. All the measures, the hand washing, the border closure, the lockdown, social distancing, and all other measures I can say that all these help us to control the number of cases. And now we are trying to relax some of these activity in order to restart the economic activity. Currently, I can say that we are on good track in managing COVID-19, but other sectors that are essential for the life of our population need to also regain activities. We also use social communication. We carry out community education and information among the community, and we involve religious organization. And one important aspect here is that our government, taking into account the poverty caused by COVID-19, we have cash transfer schemes to vulnerable families. This is under the Ministry of Social Security, and families are getting this assistance of cash transfer in order to ensure their survival. We also have community kitchens where we assist people with no shelter, street kids, and we have other kind of shelter where we host the elderly and people without shelter. We also had a campaign where we helped the street kids, giving them shelter. Well, with tracking, contact tracing, when we identify a case, we test the case and its contacts, direct and indirect contacts. This is the procedure. And the type of exam is RT-PCR. This has been helpful. We also test specific groups such as health workers and others. Such as passengers coming from different places. We have a place where all professionals that are involved in the fight against COVID are hosted and they are living, and they have no contact with their families since the process began. They only leave this place to go to work and then they come back. With regard to the professionals working in the treatment centers, they also are living in a specific facility. They work for 7 days. They go under quarantine, a 2-week quarantine. Then they spend 7 days with the families. Then they come back and they follow the same procedure. This is what Angola has been implementing. Lessons. The early implementation of these measures and restrictions and lockdown of borders and quarantine, social isolation, the use of masks, hand washing, helped us to go ahead of time. That is how the country prepared and avoided a huge number of cases, because this would increase pressure on us in terms of the need health materials and other problems, because we also face problems like malaria and other diseases. And I can say that these measures were extremely helpful, and they are assisting the country in order to fight the COVID and also get out the economic side that is deeply affected. I can also say that the multi-sectoral approach was very key, because each area plays a major role. in the management of COVID-19 in Angola. To summarize, in a nutshell, this is what I can say about Angola, and I'm ready for any question in case you have. Thank you.
Thank you very, very
Hey, Ambrose, your mic is muted, Ambrose.
Ambrose, your mic.
Oh, sorry. I was saying thank you very much, Dr. Mufinda, for your presentation and a very elaborate presentation of Angola. But also, I would like to thank the Minister for Health who has sat into this presentation and also in this webinar today. We're really very grateful for the Honorable Minister for being on the call today, and send our regards to the government and the President for the work that they have really done in Angola. And Javier Ramburu, please, we are really very grateful as well for the efforts you've made in supporting the country, and also for being able to be in this inaugural webinar. I have some questions for Angola, then there are several for South Africa, but Bukare, there is a question I can see in Portuguese, so can you read that question for me in the Q&A, the one which is in Portuguese?
Yeah, there are two questions for Angola. They're asking if the community kitchen is not a source of transmission of the virus. The second question is about the continuity of services for pregnant women and people with chronic disease. Apart from that, there was a question, a general question about human rights approach with all the intervention. Somebody was asking if they have considered the human rights aspect. Over to you.
And then there was one on involvement of the other sectors. What is your experience? How it seems to be working well? What can you share with the other countries? So let me first dive into Angola, because there are so many questions, but they're lab specific for South Africa. But Angola, if you could respond to that, and then we'll ask the question for South Africa, and then we wind up. Angola, please. Do you hear me?
He's muted. Open your mic.
Dr. Mufinda, please, your micro, yes, please, go ahead.
Sim, agradecemos
Thank you for your questions. It's not all were very clear. What I understood is that it was important to talk about multisectoral collaboration. What we did in our plan was to assign tasks to different sectors in the Angolan government, so that each sector would respond to different aspects. For instance, with respect to the media, it will be the media. What is to do with water, it will be the water department to deal with these issues. Access to water, it's very important. These circumstances when you talk about washing hands. So everybody should attend the coordination meeting. So whenever there's an issue, we should find an immediate response. If we talk about the issue of transport, so the Minister of Transport should be present to open corridors, for instance, or equipment from outside the country to arrive, or for some experts to come and assist. So these efforts around the president assist us to move forward. So this is our experience, and all this is part of our contingency plan. on the issue of human rights, in this task force, we have the Minister of Justice and Human Rights, but we also have the Ministry of Foreign Affairs, and they taking on board this issue of what relations. They deal with the 48 positive cases. There are many people that are not Angolans. We have expatriates, people that are in Angola that are infected. So there's diplomatic element there. So diplomatic approach is dealt with by the Ministry of Foreign Affairs. And they know how to deal with these specific cases. Now, human rights, these aspects are considered. Everyone that is in quarantine, they are entitled to accommodation. We provide the bed. We ensure that what is basic, like food, meals, 3 meals a day, breakfast, lunch, and dinner. And we provide soap, toothbrush, toothpaste. So we provide the package.
Porque não há violação então desses aspectos todos. As mulheres grávidas, nós estamos a
provide different treatment. If someone is a traveler or might be a contact, so the tests are organized. The other elements to provide a different treatment to these situations of pregnant women or chronic people with chronic diseases, non-communicable diseases. As we know, this can become critical to people with COVID-19. So we continue to cater for them in hospitals, in health facilities. So we ensure that there is this care that is provided, and we've set up some groups involving academicians, follow-up of all these elements. But in terms of assistance to these groups, it's all provided for. Thank you.
All right, thank you very much, colleagues from Angola. And again, want to congratulate your minister for sitting into this, and Javi as well. We have a couple of questions for Professor Ko, South Africa. One of them was, what is your experience with asymptomatic patients who had persistent, just a minute, I might be doing something here with my microphone. Yeah, what is your experience with asymptomatic patients who had persistent positivity or with RT-PCR after 30 days? Could you comment on that? The second was, what happens to the maintenance of testing services for HIV/AIDS, TB as part of essential services when these lab services are repurposed for COVID-19? And do you have any comments on the data generated with GeneXpert? They are handled because some countries are refusing to adopt GeneXpert because they think that the data is in the cloud. And then my friend Zandile said, you have very high screening, and yet the most affected province is Western Cape. What is the explanation? And then with your wide-scale community screening and testing, how do you address stigma? And then could you comment on how the NHLS ensures quality control in terms, and then how much are you seeing false positives and false negatives? And how do you select samples for pool testings, asymptomatic versus symptomatic or same geographical area? And the final one was on, let me see, just a bit. Do you test the community health workers to follow up possible COVID-19 infection during screening activities? And how is the response of communities to mass screening? I mean, there are so many questions, but I think you could take those and then we'll close. And I really thank colleagues who have stayed on to the call because I know we have exceeded our time. So if Professor Koleka, you could answer those questions, then I'll just give the closing remarks.
Yes, thank you very much for that. I think the question on the other testing services, especially for TB and HIV, is a very good question, and it's something that we are looking at. First, just to clarify, we have not actually repurposed the labs for COVID, but what we did was to look at the capacity, what's residual capacity after we've actually accommodated for HIV and TB testing. So that's how we planned. But I mean, be that as it may, we are closely monitoring that. Remember, we are also on lockdown. And so we have seen a concerning decline in patients coming in for HIV testing, or also actually for their viral load testing, or for TB as well. So that's something that's critical that we need to monitor very closely. And then the issue about the Western Cape, like I said, really, we are still trying to understand why we're having such high numbers of cases. But what we have seen for sure within the Western Cape is that the primary cases actually have come from outbreaks that we have seen in supermarkets. And now because, and if you're looking at where these hotspots are, these are in the highly densely populated areas of Cape Town. And so you find that if somebody gets, there's a case that's positive within an outbreak in Checkers, and then that individual goes back to the township, and that's how then we're getting these high cases. And like I have said, the Western Cape has got a very sophisticated system way ahead of most provinces within the country, that they're actually able to locate, they've managed to get a unique identifier for their patients. They can trace them much more efficiently than most provinces. So that's why we think they are actually testing the right communities, and that's why they're having the increase cases. And we really just think it's a matter of time, and we'll see this in the other provinces as well. In Limpopo, we really just, the issue there is that we believe that the screening that was done, and there was no actually looking at symptoms for referral to testing. So which means then they were basically testing people who had no reason to be infected, who were at very low risk, and that's why we ended up with such low positivity rates. Community screening and the stigma, I must say there are specific areas where people are concerned about stigma with testing, but it has not surfaced, to such a high level as yet. So it will be something that we need to look out for. And the community workers that go in for screening, they themselves, they do get tested, but also once then they have referred somebody for screening. So there's a team for community screening and testing that does the screening and refers for testing, and then there's a contact tracing team. So they then would refer the results from the testing to the contact tracing team to actually then manage and manage those patients that are positive and direct them as to what happens, whether they self-isolate or they go to assisted isolation areas that have been created across the country. About producing our own test kits, in fact, there's just there was an announcement that was sent from the MRC just yesterday, where we are encouraging researchers to come up with specifically really to look at whether we cannot get PCR point of care testing, because that's what really would make a big difference, rather than the centralized RT-PCR we're doing at the moment. And also to look for antigen, kits, because as there has been discussions on serology, the value of serology, especially because we're still trying to identify infections, it becomes a bit tricky. In that probably serology will be good later on in the epidemic when we're looking at prevalence or we're looking at people who have been exposed. But for now, we are, so there is actually a move and a drive for scientists to come up with these tests. And pooled testing, we have not started the pooling as yet as a country, but it's a concept that has been shared with the labs. And so the labs are still looking at that to see whether that would fit into their testing algorithms or not. And then there's a question about how this impacts on pregnant women and other chronic diseases. in fact, one of the critical things that the minister keeps raising up, and also even within the ministerial advisory committee, that we keep reminding the healthcare workers to say that we actually have got, there's a lot more. We can't then just find ourselves damaging all the gains that we have had as a country, whether it be in HIV, it's in TB, or any other, chronic diseases. And so we want to keep on reminding the clinicians that we cannot really just, so that is why we're trying to keep COVID patients out of the hospitals and manage it early, so that the hospitals can really remain for those that are sick and those that have got actually chronic diseases. So far, we really are not picking up much, but these are things that we are very careful and regarding against. Have I left anything?
Not really. I think, Professor Kollega, thank you very, very much. But let me take this opportunity really to thank all our presenters. You are very, very superb. You presented, the information you have given is very informative. I would also like to thank all the ministers who have sat in, all the ministers of health who have sat in. I know the Minister of Health online. We're really very grateful for your political leadership. I would like to thank the executive management for supporting enthusiastically our webinar series, but specifically this webinar series on sharing best practices, where we think we have to learn from each other as countries, because you can see that we are at different stages of the response. I'd like to thank the senior government officials who have been on this call, the WRs, our country representatives, for helping us to circulate this call, and our WHO country staff, and all our partners that have been on this call, and all of you who have been actually sitting into this and listening. And finally, I really would like to thank our technical officer, Bukare, who has been running with these webinars. He doesn't sleep. These are doing 2 to 3 webinars every week. Finally, I would really like to say that from the bottom of my heart, the information that has been presented today from the countries, from the response measures you put in place so quickly, from preparedness now to now response, really reassures us as WHO that maybe Africa is going to deal with this outbreak. I think when we stand together, we will control this outbreak. So let's continue our resilience. Over from me, I've really enjoyed being your moderator for today, but thank you to you all. And we give you a virtual round of applause, and let me clap from here. Thank you very much. Over and bye-bye for today.
Bye.
Bye.